I come back and do that. Yeah.
It looks like there's a how's your family doing?
All right. Good morning. How are you?
Good. I didn't get the. I read it as a. I know. I didn't read it.
Call the House Committee on Health Care to order for this September 24th. Remind us that we have a very, very tight agenda, and I'd like to make sure everybody that's on the schedule gets their fair share of time. I don't want to starve out the people who are at the end of the agenda, so I'm going to be trying to keep things moving along as well as we can. We're going to start with a report from the Oregon Health Authority. And Mr. Allen, will you join us with your team? We have an hour and 15 minutes scheduled for the OHA presentation. We have a lot of stuff on it, so say everything you need to say and not one word more.
Mr. Chair, we'll do our best.
Mr. Smith can have an extra word.
Okay. Chair Greenlick, members of the committee, Patrick Allen, Director of the Oregon Health Authority, happy to be here. Before we get into the substantive presentations we have on CCO 2.0, public health and behavioral health, I thought I'm about just a bit more than a year into the job and thought it would be useful just to take a quick minute and kind of give you an update on some of what we've been up to over the past year and some of the key organizational things that are on the horizon right now. It's, as you well know, been an exceptionally busy year. We have been involved extensively in the CCO 2.0 work, and you're going to hear a presentation about that today. We have worked to improve transparency in the agency through a variety of tools, including posting all of our public records requests and the responses to those to the internet, working to significantly increase the timeliness the agency answers those requests in. And as of about a week ago now, my calendar is posted weekly to the internet so people can see who I've been meeting with and when and those kinds of things. So we're trying to make some significant progress there. We've reorganized the agency to adopt a better focus on behavioral health and to consolidate the Medicaid program under a single Medicaid director, and both of those director positions are near the end of their recruitments right now, with a final round of interviews for the Medicaid director this week and a second round of interviews for the behavioral health director coming up shortly after that. And then most significantly to me, although kind of in the weeds a little bit organizationally, we are at the end of a process to establish a performance management system in the agency that helps give everyone in the agency a clear view of what is our mission, vision, and values. How does that translate to outcome areas that we're focused on? What are we trying to deliver for Oregonians? What are the metrics so that we know whether or not we're delivering those values? What are the processes that we have in place in the agency, and how are we doing on those processes so that we, first of all, know that we're getting the work done that we need to get done, and if things are beginning to drift off target, that we've got early warnings of those can intervene when they're minor course corrections rather than major problems. So a lot of work has been going on in the agency, and I'm really proud of the team that we have that's been doing that work. A couple of things to touch on briefly that I know are of interest. The Unity Behavioral Health Facility, there may well be questions about that. Not really in a position today to talk much about that because there is still an ongoing investigation and ongoing corrective action work there, and so I hope in December to be able to speak more directly about that topic. The last thing I wanted to touch on, just because there's been some incorrect information in the news recently, you'll all remember that we had an issue with payments to coordinated care organizations for people who were eligible for both Medicaid and Medicare, and that there were payments that were made at incorrect dollar amounts, and there was an amount of essentially overpayment. The initial dollar amount that was identified was about $70 million, but as we've reported to you multiple times, that number has long since been corrected. It was about $42 million. There's also, I think, a perception that nothing's been done about that. Of course, when that came out nearly a year ago, the governor ordered us to recoup that money, and we have done just that. We've got $23 million of the $42 million in the bank, and are collecting payments on repayment plans from a number of CCOs for the remainder. based on managing cash flow, and expect to have all of those funds collected by the end of the year. So with that, unless there are...
Back to the Unity. Are you feeling pretty comfortable about what's going on at Unity? I know you can't talk about it much.
Well, I think it's too soon to be able to say that. I think there's still an extensive ongoing process, and I want to leave it to the professionals in the Public Health Division that are working that process before I try to opine.
Thank you. Representative Vial, did you?
Thank you, Mr. Chairman. Thank you, Mr. Allen, for being here today. I just want to put a pin in the Wilsonville certificate of need issue with the mental health facility that's been proposed there. I know we're still in the process of that application and the ultimate results, but I would hope that maybe by December ledge days we could get a fairly thorough report from your office on that whole certificate of need concept and how you feel like it worked with respect to the particular project that we're talking about.
Yeah, Chair Green, like Representative Vial, happy to do that. It will need to be relatively generic if we're still in a mediation process as we are today. And as you are probably aware that there's still due process involved in that in terms of the ability to appeal the decision and those kinds of things. So if we're still in that kind of a mix, it'll have to be a more generic presentation about certificate of need, but we can certainly do that.
Thank you, Mr. Chairman.
Representative Bueller?
Yeah. Thank you, Chair Greenlick. Pat, I appreciate your update. Why is there a payment plan for the overpayments when there is, my understanding, a payout of large amount of money for bonus payments to CCOs? How can we have a payment plan when you just paid out millions in bonus?
Yeah, Chair Green, like Representative Bueller, a bonus is probably, I presume you're talking about the quality incentive pool, and a bonus is probably not exactly the right way to think of that dollar amount. What there really is, there are payments to coordinated care organizations, partly that are based on capitated actuarial rates and partly that are based on achieving benchmarks for improving quality, and those are part of how CCOs pay for the work that they do. And so what we've tried to do in the recoupment is work with each CCO to manage their cash flow given all of their circumstances of cash in and cash out in a way that that makes sense. But as I say, this should be a moot point shortly, as those plans will end by the end of the year.
Thank you.
Thanks. Are we ready to move on to CCO 2.0?
Great.
And in that case, I'll turn it over to Jeremy Van de Hey.
Great. Chair Greenlight, members of the committee, good morning. My name is Jeremy Van de Hey. I'm the Director for Health Policy and Analytics with the Oregon Health Authority. And I'll let Zeke introduce himself, too.
Chair Greenlight, members of the committee, glad to be here. I'm Zeke Smith. I'm the Chair of the Oregon Health Policy Board.
I know this is a big topic. We don't have a ton of time. I know we've tried to schedule some one-on-ones with folks as well, but happy to talk offline if we don't get through all your questions today. This first slide's pretty busy, but really what it's trying to show is that we're nearing the end of a lot of work this year to really set the stage for the next CCO contracts. Just a refresher, CCO 2.0 is collectively what we're calling the phase of building towards the next 5-year contracts for CCOs, which will begin on January 1, 2020. I'll talk a little bit more about what 2019 is going to look like in a minute, but it will take us most of really the entire calendar year of 2019 to get through the formal procurement process. So this year has really been the year that we've been focused on reflecting on progress under the CCO model and getting clear about goals for the next 5 years and engaging with the public. The Health Policy Board has really been leading that work, and we've had several phases throughout the year of public engagement. Started with the Health Policy Board holding a retreat in January, where they heard from John McConnell from OHSU and others around progress CCOs have made. And then they spent the spring and the summer getting public input, hearing from folks on where we could have some improvement, and beginning to narrow some ideas for what we could be focused on for the next phase of CCO contracts. We've had a pretty significant amount of public engagement throughout the year. We started with about 30 committee meetings back in March, April, and May, various committees that OHA has or under the Oregon Health Policy Board, soliciting feedback from them. Did 4 rounds of town halls in April. did an initial online survey. We had about 1,600 folks respond to, and that was sort of our first round of casting a wide net on ideas folks had for where CCOs could improve or focus in 2.0. Then this summer, the next phase, we did another round of 10 town halls around the state, as well as a all Spanish-speaking town hall in Woodburn just recently. I did a second survey. We had almost 400 folks respond to that. And then we just recently did a phone survey of members. I'd say, we'll talk in a little bit more detail towards the end of this presentation around some of the policy ideas that we're looking at. But really, there's four main buckets: improving behavioral health, focusing on value-based payment, focusing more on social determinants of health and health equity, and continuing to hold down costs. And what we heard from folks throughout the various input processes that we had, be it the survey or the public forum or the member survey, that those are really the four focus areas that folks are most interested in. So generally, we're on the right track in terms of things we feel like we need to address in 2.0. We also have some really great news in terms of where member satisfaction with OHP and where they're at. About 90% of OHP members that we surveyed, this was a sample size. It was a random phone call survey. We had 90% of folks either satisfied or very satisfied with OHP, which is really positive news. Not on this slide, but also strong support for those four areas that I just outlined as well. So going through kind of a high level, the overall timeline, as you can see, we're sort of in the midst here. I mean, this work really started back with the Health Policy Board doing a listening tour back in 2017, and it'll end with new contracts starting January 2020. Some of the kind of nuts, before we get into some of the policy priorities for 2.0, some of the kind of nuts and bolts of how the procurement will work. First, we're going to do this through a request for application process. This was the same process that was done in 2012. And what that really means is that we aren't picking a predetermined number of CCOs. In a normal request for a proposal process, you would score folks and you would pick the top 1 or 5 or however many contractors you want. And this process will set criteria, and those organizations that can demonstrate that they meet the criteria will be awarded a contract. We're also, that RFA will go out in January. We're anticipating having a letters of intent due the following month before the applications are due in March or April, and that will give us a sense of the lay of the land and let folks know who's applying. We're also considering, but still working through the details of some service area issues and application regions, and trying to think through how we'll balance both not sort of forcing disruption in service area, but also making sure that we've got the entire state covered. So one of the things we're looking at is whether to have organizations apply based on regions. And we're still working through those details, and I hope to land a decision in October. Stuck. I covered these briefly earlier, but again, there's really 4 key areas that we're focused on: behavioral health, social determinants of health and health equity, value-based payments, and continuing to hold down costs. We'll go to the next slide. We have a draft report right now that the Oregon Health Policy Board looked at in September, and the way that's framed up is it'll be a narrative report, but in the back of that report, we're really splitting work into 2 big buckets: things that we're anticipating will be folded into the new contracts on year 1. It may be things that take a couple years for CCOs to do, but are anticipating that it's a requirement that we build in year 1. And then a lot of things that we're anticipating we would work on probably in years 2, 3, 4, 5, once we've gotten through all of the year 1 pieces. So we assembled a pretty large list of policy options. When you've got the full packet of that on OLIS and in your materials. A short answer is, as we've been getting feedback, none of those things have really totally fallen out except for a couple. I think there's a lot of good ideas in there, but we know we can't do all of them in year 1. And so they're really thinking about what's going to go first and what's going to go in future years and be folded in later contract years. Next slide. So I'm gonna walk through at a really high level some of the policy options, and like I said, there's a lot more detail in the materials on OLIS. So in terms of behavioral health, really things have kind of boiled down to three main components. One, ensuring clear accountability of CCO for the behavioral health benefit. Second, ensuring we've got adequate network capacity for behavioral health within CCOs. And when I talk about behavioral health, I mean both substance use as well as mental health capacity. And three, honing in on some really specific behavioral health metrics that make sure folks are both getting care at the right time in the right place, but also that would indicate that the behavioral health system is improving and that, like I said, folks are getting care in the community at the right time in the right place. And I'll just say on the clear accountability for behavioral health, we have not. There's been some confusion around this. We are not saying that CCOs can't continue to subcapitate in some way, but what we really want is CCOs to really hold responsibility and be accountable for the behavioral health benefit, and not just fully delegate that out to another organization. What that really means is that when a member calls the CCO because they can't get access, that the CCO itself is going to be the one responsible for resolving that. In terms of social determinants of health and health equity, you all helped move this along in the 2018 session with House Bill 4018, which requires CCOs to make investments into social determinants of health. We're also looking at ways to improve the rate methodology to try to build in social determinants of health and health equity. I'll say the challenge of that is we know that nationally healthcare is outpacing the 3.4% trend, and so we know it's going to be harder and harder for CCOs to stay within that, but want to look to evolve the methodology to really encourage investments in prevention and reward CCOs for making those investments. One of the key things we're looking at is to really align community health improvement plan priorities at the local level. Right now, if there's multiple CCOs, they could have multiple community health improvement plans. We want to bring that together and have one plan for the community that includes both not just all of the CCOs if there's more than one, but also includes the local hospitals and local public health, all of whom do their own community health improvement plans. So the idea is to have really one guiding document eventually for each community, and have that be the resource that directs where communities invest to try to address social determinants of health. On the health equity front, there's two main priorities. One is ensuring clear accountability within CCOs for health equity. So this would require both them submitting a health equity plan as well as having a single point of accountability within the organization who's actually responsible for health equity and a health equity agenda, and then implementing recommendations for expanding use of traditional health workers and community health workers. In terms of value-based payment, what we're looking at is setting a minimum threshold that all CCOs would have to have in terms of value-based payment coming into the contract, and then a requirement at the end of the 5 years with incremental progress throughout that. And what that's looking like right now is 20% of all primary care payments would be based on value in year one, and by the end of the 5-year contract, 70% of all payments would be tied to a value-based payment. In between that, CCOs would make incremental progress year over year, and we're looking at things like, potentially each year picking a priority area. For instance, one year maybe hospitals, the next year behavioral health, to try to get some economies of scale in terms of technical assistance. And then finally, I think in terms of value-based payment, recognizing this is not just a Medicaid-specific issue, we really need to work across markets. So looking to see how CCOs can align with work happening with PEB and OEB in the commercial market to try to really align this movement from fee-for-service to value-based payment. And then the fourth area, cost growth. We've already committed to continue to hold down costs to 3.4% trend in our waiver, but we're looking at things that would help make sure we can actually get there. So one is aligning financial incentives for CCOs to better incent investments that reduce costs. This is would be a variable margin is one potential way of doing that. So if a CCO shows that they're actually reducing costs lower than the normal trend, that we have some way of rewarding them for that to try to encourage them reducing costs. Another piece is building in more specific requirements within the contracts for CCOs actually being responsible for holding down the growth. While we've committed to it in our waiver, it's not as explicit in the contract that CCOs have a role in actually making sure that they tie to a long-term sustainable rate of growth. We're looking at increasing some of the financial transparency within CCOs. That includes both some better, more consistent reporting to OHA on finances, but also includes us using total cost of care and other efficiency tools that are out there to identify where there's outlier costs within the system, so we can give that information to CCOs so they have a sense of where opportunities are to reduce costs within their region. And then finally, prescription drugs. This is a huge issue that we heard throughout all of our public engagement work. We've limited tools as a state due to federal law, but one of the things we're looking at is aligning areas of the preferred drug list where they're currently out of alignment to better maximize federal rebates. There's a whole series of things in years 2 to 5. I won't go through all of them, but just to kind of give you a sense of things that we've looked at. We've considered standing up a reinsurance program with CCOs to help with the ebbs and flows of risk. That would require legislation, so something that would be further conversation with you all if we get there. Also looking at out-year work around behavioral health, including better use of behavioral health homes and focus more on ACEs and trauma-informed care. And then finally, let's say that in terms of policy recommendations, these aren't all just for CCOs, so we're also looking at things that the agency needs to do to improve the system or make sure we're holding the system accountable. One of the things I think that was clear in 1.0 is that there were some parts within our contract and within our expectations where we're not really explicit around what the exact outcome was that we wanted. Behavioral health integration, I think, is a good example of that. So one area going into 2.0 is making sure that we're really testing all these ideas to make sure it's very clear that there's what the outcome is that we're expecting at the end of the 5-year period. We're also looking to improve the accountability work within the agency in terms of our capacity for monitoring compliance and helping with technical assistance. In the behavioral health space, one of the areas that has come up over and over again is billing codes and challenges that CCOs have and that the behavioral health system has of, one, trying to be pulled out of fee-for-service and towards value-based payment, but on the other end of the spectrum, being required to have encounter data in order to be paid for everything. So we want to do some work there and see if there's some ways we can align both align the billing codes to really incent value-based payment. I think we're probably pretty close to time, so I'll just cruise real quickly through the next steps. The Health Policy Board will wrap up its work in October. Sure.
If I might just make a comment. Thank you. I appreciated the update on the behavioral aspect. I remember back in '89, this committee passed out a bill calling for parity, because you're not healthy if you're not healthy mentally and physically.
Yep.
And just appreciate the good work. Thank you. Thank you.
In terms of next steps, the Oregon Health Policy Board will wrap up its final set of recommendations on October, and then that will really start the formal procurement process. We'll start drafting the RFA, like I said, that we posted in January. So I'm going to turn it over to Zeke, see if he has got some comments too.
Great. Chair Greenlick, committee members, again, Zeke Smith, Chair of the Health Policy Board.
Thank you. Just a quick question. I also want to comment a little bit on the behavioral health and the update that you shared with me. One thing that I've noticed as I've been talking to folks at the doors and also visiting different districts around the state with the Student Success Work Group, one of the things that has come up a lot is access to mental health support for young people and adults. But one thing that we're not talking about is the fact that we don't have enough mental health therapists who are multilingual, who are culturally sensitive. What efforts are we doing? Are you guys tying that with the equity plan at all? Is that a focus? I just want to make sure that we are paying attention on the front end as opposed to thinking about it at the far end of the work that we're doing. So I just wanted to do a quick check-in and hear from you where we're at.
Yeah, Chair Greenlake, Representative Alonzo Leon. We actually have a number of initiatives in our list of options around building out the workforce, making sure, one, that there's adequate network capacity, but also recognize that there are shortages in areas. So there's a number of things in there, including in the equity plan in terms of building out a culturally competent workforce, recognizing that, again, it's an issue that is only, Medicaid is only partly a Medicaid issue, and so we really need to tie it back to our larger workforce strategies.
I could just add to that, Chair Greenlake, Representative Alonzo Leon. That's also an element of the stuff that went by relatively quickly about recommendations of the Traditional Health Worker Commission. We're talking about peer support specialists, community health workers, those kinds of things, which we believe can be incredibly helpful in providing culturally appropriate services, especially in rural communities.
Strong interest in peer support as well, which is, I think is coming to this area. Representative Bueller,
Yeah, thanks, Chair Greenlake.
Representative Kennedy.
Jeremy, ever since I've been on this committee, I've been hearing about discussions of CCO 2.0, and it's been horribly delayed. Why is it so long in the implementation of this next version of CCOs?
If I could tackle that one, please. Chair Greenlake, Representative Bueller. Horribly delayed. I'm not sure I agree. When we came in the door in
2.5 years?
No, we delayed a year. When we came in the door to the agency in September, we were at a place where we were supposed to be executing CCO 2.0 contracts for plan year 2019, which would line it up with our waiver. I made the decision at that time that, given what had been going on at the agency for the past bit of time, that we weren't ready to be able to do an adequate job of delivering CCO 2.0. I think I maybe in this committee even suggested that at best we'd deliver CCO 1.1 if we pulled the trigger then. So after talking with a lot of stakeholders and a variety of people, I made the decision that a year delay would buy us a significantly better quality product, and that we really would deliver 2.0. And I hope you'll see, you would agree from today's presentation, that the depth of thinking, the quantity of community engagement, and the nature of the things that we're going to push the system to do have been worth that year.
Representative Kennedy.
Thank you. I'm going to ask three really brief questions, and I'm thinking that Zeke may be answering some of these as well. One is we in their 1.0 tried to give a lot of flexibility to CCOs, and we're trying to now figure out how much should be standardized. So a lot of questions have come up about prior authorization. How do we do a better job of having a little more standardization about what should require prior authorization? Secondly, in the appeals process for it, how it's handled very differently by different CCOs, so making sure that we have experts in the field that help just to determine whether denial on a prior authorization was fair or not. And then thirdly, if there is a denial, and I think this is particularly in the behavioral health arena, and if the CCO says we don't think that level of care is needed, there's a responsibility to get back to the provider and the patient to say what step down. So that whole arena, I'd like to know whether you are articulating that at all in your RFP process. So that's one. Second, would love to know more about any expectations that might be different from first time around in your consumer advisory councils. It's related to 4018, but I didn't hear too much about that. And then thirdly, there's been a lot of talk in the Student Success Committee, as well as in a committee that I'm chairing on child abuse prevention and intervention, around the need for mental health and behavioral health support in the schools. And I know one of the discussions that's coming up is how can CCOs play a part in putting counselor, social worker, behavioral health nurse, something in the schools. So unfortunately, the timing is of that committee and its recommendations is coming a little out after your RFP process. But I'd like to know what in your RFP process you're going to do to address the really burgeoning needs of kids in schools who are coming not prepared to learn because of what they're dealing with homelessness and a whole variety of other factors. And all the emerging information about
That's not exactly
trauma
a brief
informed.
question.
Okay, trauma informed. Well,
Can we have a brief answer? The answer is yes.
I'll let
more of it all.
I'll let Jeremy tackle the first two, but on the third, we're going to talk about that very topic in the behavioral health update a little bit
Great.
later this morning.
On the prior authorization piece, we didn't hear a lot of concerns about that from the public, so it would be good to maybe touch base offline around what you're hearing from constituents. The one area that does come up is around the preferred drug list, and looking at how do we align prescribing practices, and the preferred drug list is in essence a formula, and each CCO has their own, and they're by and large aligned. We found a lot of alignment, but there's some areas where there isn't alignment. I think that would help with some of the prior authorization areas, but might not hit everything that you're talking about. And then on the trying to think what the
Advisory committees.
Oh, on the advisory committees. Yeah, we did actually look at community advisory councils and are looking to in 2.0 have CCOs do a better job of making sure they actually reflect the communities and describe to us how they're building them to make sure that they actually represent the membership of the communities they serve, and are also looking at trying to bolster actual member participation within those as well as with the governing boards.
If I might quickly, Representative Kenny Geyer and Chair Greenlick, the other two pieces I would say in terms of community advisory councils, there's also a recommendation in there to increase the membership of community advisory councils on governing boards for the CCOs, and then there's a recommendation about making clearer the expectation around the ways in which community advisory councils are involved in creating the community health improvement plans for CCOs.
Thank you.
We move on.
Do you get anything else you wanted to?
Mr.
Chair
Smith,
Greenlick,
you have a
members of the committee, quickly, I just wanted to say one, just to reflect on, as I was driving down here, I was thinking about the fact that it was about 2 years ago that this committee, under Chair Greenlick's leadership, asked the Health Policy Board to take a clearer look at CCOs and our expectations moving forward. We did that, and frankly, in the first year, we got quite a bit of input. We created some kind of framing recommendations, but they didn't really get to the level of depth that I think was necessary to be able to really move forward in an effective way. I believe over the course of the last year that one of the products of this process that is reflected in that report is a level of depth and specificity in some expectations about both what CCOs should look like moving forward, the kind of work they should be doing, how that work should be accomplished, as well as the relationship between CCOs and the Oregon Health Authority. Second thing I would say about the process is I really believe that there's been an accurate reflection of the public discourse that has occurred over that course of 2 years, and key stakeholders have been providing input and information to the Health Policy Board throughout the process. And I think that that's been both a valuable exercise. I also think that the Health Authority has learned a few things about ways in which they want to engage with community members and with stakeholders moving forward, and I think that that's reflected in their expectations about the kind of work that they want to do. And lastly, I think it gives us a pretty good roadmap for where we're headed. I think that there will be in that report some clear opportunities for the legislature to take some action, which will continue to support the health transformation we're looking for. I think there is definitely a number of ways in which the Health Authority will be stepping into that role in an effective way. And as the Health Policy Board, I can tell you that we continue to see this as a really critical issue and will be engaged in helping to make sure that CCOs are reflecting the work that we need in our communities as we move forward.
I agree, and I think Mr. Allen should be congratulated for his willingness to come to the board for answers, and certainly for the board's willingness to take up some very tough questions, and I think do a great job, and I think it's improved the process enormously over what it might otherwise have been. Okay.
Great. Thank you. With that, we're going to shift gears here and ask Lillian Shirley, the Public Health Director, to come up, and we'll...
I do want to comment while we're waiting for this.
Okay.
I think the 3.4% trend, I think we have some responsibility for changing the medical trend in the community that's going against that. And I hope we'll be hearing some things later today about work that's going on, and I hope 2019 will be a big piece in trying to make it a little easier to bang against an 8% trend or a 9% trend in the community.
And we haven't quite finished the rate setting process yet, and so I can't speak to detailed numbers today. In December, we can come back. We are running above 3.4% in one metric right now, and medical trend is running higher. And I think your point is well taken that this is more than just a CCO mission. It's a community-wide mission.
There's only so much stream you can swim up again.
Indeed. With that, I'd like to turn the mic over to Lillian Shirley to talk about public health modernization.
Thank you, Director Allen. Chair Greenleaf, members of the committee, my name is Lillian Shirley, and I'm the Director of Public Health in the Public Health Division in the Oregon Health Authority. And thank you for inviting me today to provide an update on public health modernization. I'm going to start with a quick review of what we've accomplished, including the general fund investment that you all made in public health modernization in the 2017-19 biennium. And I'm going to review our priorities and discuss what we'd like to achieve moving forward for both state and local communities in 2019-21. So we know that 80% of what shapes our health actually happens outside of the doctor's office, and public health pursues its vision of lifelong health for every Oregonian by protecting people from communicable diseases, preparing for and responding to emergencies, limiting environmental risks to human health, promoting health and countering the impacts of disease and injury, and ensuring equitable access to quality health care. So the landscape for public health has changed dramatically in recent years as where we live, travel, work, and play has changed. Today's public health challenges are new and increasingly complex. International travel has led to opportunities for the spread of local diseases like Zika and West Nile virus. And changes in Oregon's climate have made the state much more susceptible to certain acute and communicable diseases, such as cyanotoxins that were previously not a significant health issue in Oregon, and other vector-borne diseases. The demands on Oregon's public health system have continued to increase exponentially as the rate of public health investment, particularly in environmental health, has remained flat or decreased. But we're on the right path, and that is to continue our work to transform into a modern public health system that has the tools, the skills, the resources, and be able to prepare and respond for emerging health threats. We've outlined with you and the legislature and with our counties the roadmap for this. So this slide just is a history of the timeline. Above the line, you'll see the work that the legislature has done in directing and setting the goals for public health modernization. And below the line are the activities that we've done both in the state and as well as in our local communities to implement the legislation. For the rest of the presentation, I'm going to focus on sharing some early results that we've had from the 2017 legislative investment. So as you recall, we received $5 million investment in 2017. $3.9 million went out to local public health authorities, and $1.1 million went to the Public Health Division in the Oregon Health Authority to improve the collection, reporting, and sharing of population health data. The goals for the legislature's $5 million investment were to build a sustainable infrastructure for new models of public health service delivery, establish new local systems for communicable disease control, and increase accountability for health outcomes, and also to work to eliminate health disparities. These are the 4 goals we are still working toward with this 2017 investment. So the map before you shows the areas of the state that that received these investments as we took them out in an RFA. And I'll just mention we reached 33 of 36 counties, and on the map you'll see Yamhill and Josephine County. They opted not to apply for these dollars, but they were making strides within the framework that we outlined for how to modernize the public health system across. Walla County has transferred its public health authority to the Oregon Health Authority, so that's why you see it up there in white as well. The Oregon Health Authority required that your local public health authorities work with at least one other local public health authority and another partner to implement regional communicable disease control strategies that aim to eliminate health disparities in our state across the agencies. The local public health partnership is focusing on significant communicable disease threats within their own communities. So they've identified what it is they want to work on within that framework. And that ranges from sexually transmitted infections, hepatitis, latent tuberculosis, and improving immunization rates both for adolescents and for older Oregonians. We're learning about what works for making improvements in these areas, and we will scale up efforts and effectively have these solutions spread across the state in the coming years. So here's our some early evaluation results. During the first 6 months of the public health modernization, we've had new and expanded intergovernmental partnerships. We've increased surge capacity for outbreak investigations and better preparation for public health emergencies. Local public health authorities have created or expanded upon intergovernmental partnerships through both formal policies, memorandum of understanding, and cross-jurisdictional sharing arrangements. The formal arrangements ensure the sustainability of joint coordination and resource sharing that can be applied to all future programs and capabilities. Increased surge capacity has largely come from newly hired regional epidemiologists, infection prevention specialists, and communicable disease investigators at the local level. Surge capacity ensures that every community can lead field investigations in their own communities for outbreaks and epidemics, and is directly supporting counties with fewer resources to conduct routine investigations. The new communicable disease, for example, investigator in Eastern Oregon in the first 4 months of that position has already logged 60 hours of regional investigation for communicable diseases across Eastern Oregon. So we're better prepared with this resource sharing. Early 3 key findings. The second finding was that our expanded partnerships with tribes and regional health equity coalitions are giving us information to make better decisions. Their assessments ensure health equity and that community engagement principles are embedded in all of our communicable disease and emergency preparedness preparations and investigations. Some regions have included tribes and regional health equity coalitions in their regional governance structures, and others have paid partners for participating in steering and work plan committees to implement regional work. The third key finding is there is improved accountability for outcomes through healthcare partnerships. Local public health authorities are working and toward improved accountability for our own metrics and outcomes through partnerships with CCOs and healthcare providers. We're partnering with CCOs and working with these healthcare providers to implement new systems of public health across service delivery, including providing big example from this last investment was pneumococcal disease vaccinations in hospital settings. Lyon County is working with hospital systems to increase the number of high-risk patients who receive pneumococcal vaccination upon hospital discharge. This has the potential to significantly reduce preventable disease and avoidable costs to the healthcare systems. And several local public health authorities are implementing strategies to improve public health accountability metrics, including those around gonorrhea rates, which are exploding in the state of Oregon, as well as childhood immunizations. We look forward to reporting on changes in the next Public Health Accountability Metrics report, which will be released and sent to you early 2019. Some other examples in Central Oregon, they've used their public health modernization funds to create a new Central Oregon Regional Community Prevention Specialist for surveillance response. This team has done work around the majority of outbreaks in Central Oregon, specifically focusing on long-term facilities. Prior to the funding, which you all invested, local public health authorities had no relationship with their long-term care facilities, except to follow up when outbreaks had already occurred. These funds have now allowed the team to partner with long-term care facilities to prevent the spread of disease among this very vulnerable population. We believe that we will have fewer outbreaks, fewer disease incidents, and also be able to quicker end these when they do occur. The partnership includes training and resources to long-term care infection staff, having these care facilities complete infection control assessments and response plans, and plan we're planning for an intensive flu vaccination campaign with these institutions. And why is this important? Just one quick statistic. In the past 5 years in Deschutes, Crook, and Jefferson counties, 90% of all flu outbreaks occurred in long-term care facilities. And those flu outbreaks resulted in 44 emergency room visits, 38 overnight hospitalizations, and 6 deaths of residents in long-term care facilities. So, Oregon's most recent emerging health issues include detection of new unregulated contaminants in Oregon's water supply and wildfire smoke. Threats to our drinking water supply are expected to become more common as a result of environmental changes. In Oregon, what used to be a wildfire event is now a wildfire season. Oregon communities are coming together to address these threats, but continued progress toward a modern public health system is essential for us to build that resiliency to these threats, to mitigate their effects on the population, and plan and implement for future events. So the next phase for modernizing public health, our goals for 2019. Build on the work to better respond to emergencies, as well as emerging threats to communicable disease according to our changing climate conditions. Get better at using and sharing data and partnerships to create resilient communities that are prepared to respond to health threats, and where planning is inclusive of priority populations in each of these communities. And hone our partnerships with other state and local agencies to identify shared goals and resources. So in 2016, the Public Health Advisory Board adopted a phased-in approach for modernizing Oregon's public health system. And we are still on that roadmap. The board confirmed these phases as a pathway to modernization in 2018. We did, as you may recall, a very thorough assessment of both state capacity and local capacities throughout the state, county by county. And we are still looking at the results of that assessment to guide how we prioritize our investments and how we can judge what our results are. With the investment that we made in 2017, we focused on increasing the capacity to prevent communicable diseases. Obviously, that was all my results that I was telling you from our report, and addressing the health disparities across the system. If further investment is made, we'll continue to build that greater environmental health capacity from a shored-up capacity in emergency preparedness, placing public health at the forefront of these local planning implementation to protect people from emerging environmental health threats. So we have also uploaded, I think, in your documents, the official report for the evaluation for you to see in more detail going forward. So we thank you for this opportunity. We're staying true to your guidance, and we look forward to continued progress.
I've said before that I thought the Public Health Advisory Board's approach was not right at the time. We had some pretty serious discussions. I realize now I was wrong and they were right. And I think the direction that it's gone has been quite amazing. The fact that we were able to improve public health across 33 counties of the 36, and I've asked the folks at Public Health to be talking to our colleagues from each of the districts, because I think we made improvements in the public health capacity in virtually every one of our 60 districts. Thank you very much. Keep up the great work.
Thank you, Chair Greenlee.
Mr. Allen?
We're going to move on to our next topic, which is behavioral health, and we'll get another shift change here and ask Dr. Dana Harganani, our Chief Medical Officer, to join me.
Brought all sorts of people to protect you.
Pretty much. Well, a year ago, I would talk about the fact that I came into this job knowing almost nothing about behavioral health, and I know a little bit more, and here I am about to do a presentation on it, so go figure.
Shows you don't have to know anything to be successful.
Well, Chair Greenlick, members of the committee, we'd like to spend a little bit of time today talking about a variety of behavioral health issues, a little bit of time on some activities that have been underway in the last little while, some things that are immediately on the horizon, and then some longer-term topics today. You're really going to hear, I think, especially around issues around behavioral health for kids, behavioral health initiatives around veterans, and work that we're doing on substance use disorders. There's a whole background of work that's going on around behavioral health having to do with the Department of Justice performance plan, our implementation under that. And of course, as I talked about in my opening comments, we're in the midst, hopefully, the final stages of recruiting a behavioral health director who will lead the newly reconstituted behavioral health program within the agency. And so lots of good work has been going on and continues to go on, but I expect that to be able to accelerate as we are able to fully implement that organizational change. So let me just talk a little bit about some of the current things that have been going on in behavioral health. We've expanded a variety of evidence-based treatments that I want to just touch on briefly. Assertive community treatment is a powerful, important, and expensive mode of treatment that really is community-based, and the idea is to assemble a team that work with people with serious and persistent mental illness in their community, ideally in their housed setting so that can be preserved, but in their unhoused setting, if that's the circumstance that they're in, to wrap around them a variety of services to help keep them in their community and keep their condition stabilized. Mobile crisis services are now available in every county across the state. And we're in the mid-stage of the pilot project around certified community behavioral health centers. This sort of takes the notion of integrated care, where you talk about behavioral health being integrated into physical health, and turns it around and creates a behavioral health care home that has physical health care integrated with it. And it's an ideal kind of an arrangement, again, for people with more significant behavioral health issues. I want to talk a little bit about school-based mental health services, and there are really sort of two channels of investment that are going on here, part through the Public Health Division and part through the Oregon Health Plan. $6.8 million goes through the Public Health Division, which operates the mental health expansion grants through the school-based health centers. 100% of school-based health centers now have a mental health provider on site, but the need is far outpacing that investment. 76 school-based health centers all provide health services. 55 of the 76 SBHCs receive mental health expansion grant funds. Additional funding was allocated during the 2018 legislative session to support school-based mental health services. This additional funding was awarded to 6 counties based on existing need and lack of mental health providers per 1,000 residents. So basically a look at where was the greatest need and what investment could be made. During the 2016-17 school year, nearly 5,000 clients of school-based health centers received care from a mental health professional over the course of about 35,000 visits by those individuals. The top 5 diagnoses in that school-based health clinic setting were generalized anxiety disorder, PTSD, depression, adjustment disorder, and ADHD. That's the school-based health center channel of investment through public health. Separate from that, we've allocated $1.7 million through the Health Systems Division for primarily rural underserved counties. All but 2 of these are in school districts that do not have a school-based health center. This funding goes through the County Mental Health Program as part of the existing stream of funding that we provide to those organizations. Counties, we focused on schools that don't have clinics, counties with elevated risk factors related to behavioral health according to the 2000 Oregon Healthy Teens Survey, reported availability of school-based behavioral health services, and commitment to partnership with the school district. 43 of the 45 sites for this program place therapists directly in schools, and 43 of the 45 funded schools have no health clinics. The 2 funded schools with a clinic have very high mental health needs, and so that additional investment seemed appropriate. CCO relationships with schools vary. School-based health centers can bill the Oregon Health Plan, but only about half of the patients seen by clinics are on the Oregon Health Plan. And so when we talk in CCO 2.0 about how to elevate the discussion from the Oregon Health Plan to the community, this really is, I think, emblematic of the kind of challenge we have, where if all you're trying to do is focus investment and work on people who are on the health plan, there's a big piece of the problem that you're missing. And so we're trying to get a better focus on that. And this is a simple looking but powerful graph that I think shows the benefit. This is around teen suicide. The dashed line are schools that do not have increased mental health providers, and you can see the suicide rate increasing. And we're able to actually have a meaningful impact on decreasing suicides in schools where we do make these investments. And so this is the kind of behavioral health investment that we think matters and matters a very great deal. I'd like to turn to Veterans Behavioral Health Services. We'll have a more detailed presentation later this week at the Veterans and Emergency Preparedness Committee over on the Senate side. And those materials, if they're not already, will be up on OLIS. But I do want to touch on the fact that we've got basically a $2.5 million funding stream. We've been working together with the Oregon Department of Veterans Affairs and the U.S. Department of Veterans Affairs to identify outcomes and investments for that. The basic channels are to improve behavioral health outcomes and support through providing access to best practice peer-to-peer programs which are not available in defined areas. And so what we're really talking about are veterans working with veterans on behavioral health issues, and we think that's really, really important. We want to develop or improve veteran suicide prevention programs through enhanced training. We've got 9 statewide trainings for clinical providers that are coming in 2019. At the request specifically of the Oregon Department of Veterans Affairs, we've funded and hired a behavioral health veterans liaison within the agency to help coordinate, within OHA, to help coordinate this work. And we've identified best practice behavioral health treatments that fit the needs of Oregon veterans. We commissioned a study that's looking and has looked at the gaps in services, and again has emphasized a strong focus on talking to veterans and identifying these gaps from the perspective of veterans and the providers that see them.
Mr. Allen,
Yeah.
Representative Alonzo Leon.
Yes, thank you so much, Chair. Quick question. Did I hear correct that we have 45 health-based school health centers around the state?
No, that's we have there are more than that. That's the number that 45 was the number of sites where we made investments on the non-clinic side around school-based behavioral health, and 43 weren't clinic sites and 2 were.
Thank you. So do you have a number of how many health-based health centers are around the state? How many districts?
Yeah, 76.
76. Do you know how many school districts we have?
130 some. I want to say.
197.
197, okay. So obviously.
Have a lottery, a range somewhere between 8 and 200, I think.
So I wanted to bring those numbers out because obviously we don't have health-based centers, and sometimes those are the places where families and community come and get their health care. So this could be something that we could invest more in. And then I also wanted to touch on peer support. I know you mentioned in the veterans, but not in the youth area. I understand we have a couple organizations that do suicide prevention, and
Lines for Life, as an example, has a teen peer support.
That's exactly right. And I just met them last week, and so want to make sure that we give them a shout out because they do a lot of great work with youth also. One of them mentioned to me, as young people, I don't want to talk to a 40-year-old person. And that's them being 16 and 15, and I'm thinking, I'm 43. So they don't want to talk to me. They want to talk to somebody their age around issues that are impacting them socially and emotionally. And so, just curious about what are we doing to support those organizations, because obviously they're working.
And we do provide funding that helps support those programs and efforts as well.
Representative Vial?
Pat, do we have any data that's telling us why the big uptick in schools and what these kids are presenting with? In other words, what's the real problem? Why are we seeing so much more demand?
Yeah, that's Chair Greenlick, Representative Vial. That's a great question. As you know, in my spare time, I sit on my local school board, and we certainly see those kinds of upticks in things like violent behavior by kids and those kinds of things. I think in terms of data, data is hard to come by to get specific answers. I think there is a lot of general speculation that what we're really seeing are outcomes of addiction issues, especially around opioids, and how those create much higher rates of trauma among very young children who are arriving at school, experiencing those traumas, and then acting them out in a variety of ways. That's why the governor has focused so much effort on the what we call the P5 space, prenatal to age 5, to talk about how to treat addiction at the family level, thinking about kids and their care providers, often mothers, talking about how the health system can make appropriate investments at those very early ages so that kids show up ready to learn.
I think we've got a topic later in the session today that we'll be talking about adverse events in kids. So let's look for that.
Well, and just as a follow-up, Chair Greenlick, I appreciate that. I really would like to see more concrete data, and that sounds logical, but still a bit anecdotal, and it'd be nice to back it up.
Let me see what we do have that I can submit to the committee.
Thanks.
Representative Bueller.
Thanks, Chair Greenlick. Pat, would you anticipate that the governor's going to recommend once again shutting the psychiatric hospital in Junction City in her budget this time?
Well, the governor's budget comes out in December, and I would expect it will be reflective of the policy priorities she's identified around kids, around health, around schools, those kinds of things.
So that means she's going to be recommending shutting down the psychiatric hospital in Junction City once again?
That's not what it means. No.
So what's the answer?
I sit on the advisory board of the State House. I haven't seen any indication that that's what's coming.
Should we move on to substance use disorder?
Representative Bowles?
Just real quick, I could talk about this for a long time, but I was hoping to get the providers in schools that you were talking about. Is there some sort of a map or just a list of counties or where they're at that you can get to us?
Yeah, we can provide that
That'd be
for
great.
sure.
Thanks.
Okay, finish up.
Yeah, let me talk about just briefly before I turn things over to Dr. Harganani about substance use disorder and recovery. House Bill 4143 directed us to design and implement 4 pilot projects to use peers to facilitate access to care for opioid use disorders. Project coordinator has been hired, and we're hiring an evaluation team. Examples of projects, we've identified projects around the state. Coos County is proposing to place peers in emergency departments as a way to improve access to care. Multnomah County will provide peers in hospitals to facilitate access to services across all levels of care. I think you're going to hear about this in a later presentation. We've also got efforts in Marion and Jackson County. We're using federal opioid funding to expand on the pilots and try to increase those services. This emphasis on peers and other elements of traditional health workers, I think, is something that you're going to hear repeatedly from us in a variety of settings. We think this is a powerful tool to deal with not only access to service but health equity and really be able to make some progress in terms of things like culturally relevant services and those kinds of issues. We also are submitting a federal substance use disorder waiver at the invitation of the Centers for Medicare and Medicaid Services. CMS is encouraging states to apply for these waivers. Right now, states cannot use Medicaid funds in most facilities. There's a thing many of you, I'm sure, have heard of, the IMD exclusion. It's Institutes of Mental Disease. Basically, you can't spend Medicaid in a facility that has 16 or more beds. What we would be doing is proposing in terms of SUD treatment to be able to waive out of that limitation, which would expand the range of facilities available for services and be able to increase our ability to serve patients. Oregon's received $6.5 million over 2 years from the federal government to combat the opioid crisis. We'll be receiving an additional $7.75 million over the next 2 years. Some of the funded programs include expansion of opioid use disorder treatment programs in rural communities, pilot projects to provide peers with medication-assisted treatment in jails, provide naloxone to first responders to counter opioid use overdoses. And in general, we've worked to increase the availability of naloxone around the community by expanding access to who can who can use naloxone. We're preventing overdoses at a fundamental level. And just a quick graph around data on that. The purple line is pharmaceutical and synthetic opioids, and you can see a long-term decrease in deaths. You can see that heroin deaths are about flat, and unfortunately methamphetamine and other stimulant deaths have increased. The data source for this, by the way, are from Vital Records. This is death certificate data, so it's a pretty solid data source in terms of where we're identifying this. So we're making significant progress on opioids. This, however, I think helps show why the focus really needs to be broadened to think in terms of addiction and recovery generally, rather than sort of moving from one drug to another.
Mr. Chair, I just wanted to add the importance of also measuring alcohol.
Yes. Mm-hmm.
Yeah, that's a really good point.
With that, we've been working on sharpening our focus in the Portland metropolitan area as an outgrowth of the behavioral health collaborative work that's been done over some time in the agency. To talk about that regional work, I'd like to turn the mic over to Dr. Dana Harganani.
Good morning, Chair Greenlick and members of the committee. My name is Dana Harganani. I serve as the Chief Medical Officer for the Oregon Health Authority, and I'm pleased to be here with you today. We have kept you abreast a bit of the planning that's gone into launching a regional behavioral health effort in the Portland Tri-County effort region. I just wanted to share with you today an update of that work that will be launching here soon. The initiative will really be structured to bring together key stakeholders and partners, including people with lived experience, to prevent and address the challenges regarding behavioral health in the Portland Tri-County region. And I'll just briefly state, we have spent some time understanding where we can commit our best effort to support a regional effort, and focused on the Tri-County area for really three main reasons. One, certainly as we experienced the closure of family care, some of the challenges around behavioral health really came to be central in our community conversations, and felt like the opportunity for addressing those challenges was really present with this initiative. Secondly, we clearly had committed partners in the region who are ready to launch this effort with us. And given the population center of the Tri-County area, we thought it would be both an ample opportunity to learn from the work we do, as well as to have significant impact. And as OHA has entered this space, with our leadership and commitment to this work, we're really focused on an action-oriented approach. We're really looking for fairly short-term measurable outcomes. We're going to learn a lot about the system challenges along the way and hope to be able to address those alongside, but really want to use this as an effort to show success and be able to measure that success. This is a very high-level timeline that I'll just briefly provide. Again, this is coming off the heels of a larger behavioral health effort at a state level a couple of years ago, really launching into this summer now to focus on the Portland Tri-County area. We brought together about 35 leaders this summer, a diverse set of group to really help us ensure we've got full commitment across different representatives in the area to engage in this work with us, and to help to have them really identify where the priorities are and what areas are particularly ripe for impact in the very short term. We spent the summer hosting those meetings and are gearing up to really launch the first regional initiative meeting here in November. This fall will be really focused on identifying specific strategies. It will be looking at the data, identifying the measure points that we're going to be looking at for success over the next year, with really starting to report on that data as early as next summer. Over the summer, looking at both data of the region and hearing from these leaders, we've identified that the focus of this year one initiative is going to be looking at peer-delivered services with an emphasis particularly around addressing issues for substance use disorder. We're looking to bridge together all the right stakeholders in the community that can really help us look at a recovery-focused system of care in the behavioral health system, and that will be our really year one focus we're diving into here soon. It's important to note that we're making sure all the right stakeholders are at the table as we launch to inform what those explicit strategies will be. So I don't can't tell you specifically what those are yet, and look forward to reporting back on that. But we, as a group, have really identified the key principles which will really drive the work we do as outlined here, but really focus on trauma-informed care, culturally and linguistically responsive care, recovery focus, and integrated systems of care. I will give you an example, though. Over this summer, we really have, with our partners, identified some of the key strategies that already exist in the Tri-County region that we know can be leveraged or expanded, and anticipate these will be really central in the work of the initiative moving forward. I'll just give you a couple examples. One, there's some great work being done on the integration of peer-delivered services in addition to pregnancy care for women affected by substance use disorder. We know there's a lot of efforts to wrap around supports for children and families affected by SUD to address the trauma experience that they're having, and that's going to be a big focus. There are some great models around delivery of medication-assisted treatment, or MAT, in the community that we can expand upon. We know that integration for individuals who have co-occurring mental health and substance use disorders is a key issue. And there's some really great examples, some that we've spoken to already, about the integration of peer support programs in schools, for example, particularly focused on youth suicide prevention, as well as with emergency responders and law enforcement to really wrap around the recovery focus for individuals affected by SUD. And these are areas we look to leverage in the community that already exist. And I'll end quickly by just saying one of the, I think, key elements of the initiative at its really clear outset has been that we're bringing in an equity lens to really focus at a core center of this work that we're doing. We've had some leaders already come to the table to help really draft what that equity lens should look like as we launch this initiative. And while we expect it will be integrated throughout, you can see here some of the really clear ways that we're going to be asking the right questions as we do this work. Who's at the table? What are the outcomes we're looking for? What are the strategies? How do we govern, and what governance do we have? And we're certainly getting a lot of leadership from the local community, as well as our Office of Equity and Inclusion, to lead this work. So I think that covers the overview.
Representative Hayden.
Thank you, Chair Greenlick, and thank you for particularly efforts on peer support services, something that I'm interested in. I think is also, I also think that's vital to helping solve some of these issues. Just locally in my community, we had 5 heroin overdoses over the weekend, and Narcan, I think, corrected those, at least 3 of them. I haven't heard the report on the last 2. 5.
Did they survive?
Yeah, at least 3 did. I hadn't heard the report on the last 2. And that was just on a 24-hour period. So, I mean, it is a serious problem. But my question is on peer support services. I notice on procurement website, Oregon State Hospital has a request for people to apply for peer services. It seems like a barrier for an employee to go through complicated website to apply for that type of job. Why aren't they hired internally, or do I not understand that correctly?
Chair Greenlick, Representative Hayden, I'll need to look into that for a detailed answer. I would say the fact that it's on Orphan means that we're trying to move resources more quickly and out into those services, and trying to be more flexible with contracted services rather than hiring full-blown employees. But let me look into that and see if I can get the committee a more detailed
OHA
answer.
4612-18.
Thank you.
I was just curious when I saw it on there.
Thank you very much. Thank you.
With that, I
Very
think we've left a
interesting
minute
report.
of our hour and 15. If there are any other topics you'd like us to handle.
I just want to thank you for the work in this direction and encourage all of us to be really bold and step it up. I know that our access to addiction services remains among the lowest in the country, and we've really, a lot of great models out there. We just need to scale it up. I think Oregon Recovers, that organization, that alliance of groups, has been a real blessing in helping push us in that direction and reminding us that alcohol is a big part of the problem as well. New leadership at the Alcohol and Drug Policy Commission, working with Oregon Recovers and others, I think those are all really bright spots. The Suicide Prevention Alliance, I believe, is statutorily scheduled to end after its 5 years of work, and I hope that we will continue the work that they've been doing. So that and peer support services, and making sure that women, because the first year of life is the most is the time that most children are at risk of child abuse and neglect and taken away. And to take kids away from moms who are trying to go through treatment creates more trauma all the way around. So big implications on the child welfare system as well. So thank you for the work, and let's be bold this next session to really step it up.
Thank you, Chair Greenlick. Representative Kenny Geyer, thank you for that. I went back to this graph just real quickly. You reminded me of something that I dug into myself about 6 months ago about the issue of alcohol and why don't we show deaths from alcohol in the same fashion. And it was interesting to me, it may be interesting to you. The challenge is that a death from an overdose of heroin is a pretty straightforward thing to identify on a death certificate. A death related to abuse of alcohol is far more complicated and results in conditions that may or may not have stemmed from alcohol, and thus it's impossible to display it in this kind of a fashion. But your point about the impacts of alcohol abuse are well taken.
Thank you very much for your presentation.
Thank you.
We've asked DCBS to give us a very brief presentation. We have about 15 minutes. Mr. Smith, will you join us, please? Sorry to shortchange you, but you're not the only ones. I'll be shortchanged the rest of this morning.
Good morning, Chair Greenlick, members of the committee. For the record, I'm Cameron Smith, the Director of the Department of Consumer and Business Services. And with me, I have Andrew Stolfi, Oregon Insurance Commissioner and Administrator for the Division of Financial Regulation, as well as Rick Blackwell, our Policy Manager for DFR. And with that packed agenda here today, we will be brief, but happy to take any questions that come up during the presentation or at the end. As an overview, we have seen a lot of changes in health policy at the federal level over the last year and a half. Multiple efforts in Congress to repeal the Affordable Care Act, reduced support for the marketplace, zeroing out of the penalties for individual mandate in the tax reform efforts last December, as well as changes for both short-term limited duration plans and association plans. We also have an overarching lawsuit that's still pending against the Affordable Care Act in federal court in Texas. All of this has added uncertainty for both Oregonians and their families, as well as insurance carriers offering plans. But with the update you'll hear today, things have been relatively stable in the market here in Oregon. But with that good news, do not want to lose sight that for far too many Oregonians, healthcare costs are still far too high. And before I hand over to Andrew for details on our rate review and specific stabilization efforts, just want to emphasize how essential the Oregon Reinsurance Program has been to helping keep costs down for Oregonians. For plan year 2018 and 2019, that reinsurance program has helped hold down rates by about 6%. And that's going to be, so we have funding for those 2 years, and it will be a key part of the health funding discussion for all of you in 2019
you
going
mean 6
forward.
percentage points? Or you...
Say that again, Chair Greenlick.
You mean 6 percentage points, rather than 12% increase, it's a 6%
Correct.
increase?
So it has helped hold down rates by about 6%. And I'll hand over to Andrew.
Thank you, Director. Good morning, Chair Greenlick, members of the committee. Oliver, for the record, my name is Andrew Stolfi. I'm the Insurance Commissioner and Administrator of the Division of Financial Regulation. I'll talk to you briefly about rate review, the rates that were set for 2019, and short-term plans and association health plans. To start with rate review, in July, following a thorough and transparent review process, the 2019 rates for the individual and small employer plans were approved and announced. To put those rates into context, I could tell you for the current or 2018 plan year, we have 7 insurers offering plans in the individual market, with multiple plans being offered in each of Oregon's 36 counties. Initial rate requests for 2018 were between 6.9% and 20.7% increase, with final rates for 2018 landing at between 3.5% and 19.2%. In the small group market, we currently have 9 carriers offering plans around the state. Initial small group rate requests for 2018 were between 1.8% and an 8.5% increase, with final rate decisions coming in between 3.3% and 10.1%. Against that background, for 2019 rates, these were filed by our carriers in May of this year, went through a rigorous and transparent review process, which included public hearings and public comments to make sure consumers were provided an opportunity to weigh in on the health plans that affect them and make sure that the rates adequately cover health care costs without being too high or too low. In the individual market, the division approved rates for 7 companies with average rate changes ranging from a 9.6% decrease to a 10.1% increase. This compares to initial rate requests, which ranged from a negative 9.6% to 16.3% increase. Put that into context as well, a single weighted statewide rate for 2019 increase of 7.3%. This compares to 2018, a single rate of 13.8%, 2017, 27%, and 2016 of 23%. Additionally, can note that all the carriers maintained their current service areas, with 2 insurers increasing their coverage. Kaiser expanded into Lane County, and Pacific Source expanded into both Lane and Yamhill counties. In the small group market, we approved rates for 9 companies with average rates ranging from a 4% decrease to a 7.2% increase, compared to initial rate requests for a 4% decrease to a 9.4% increase. Those are the ranges. The single statewide weighted average for 2019 is a 2.1% increase. This compares to 2018 of 8.2% and 2017 of 4.6%. Turning to 2 federal rules you probably have heard of in our responses on short-term limited duration plans. In August, the Trump administration finalized a new federal rule intended to expand short-term limited duration health policies. These are plans which were originally designed to fill short gaps between coverage, generally do not cover essential health benefits, pre-existing conditions, and have relatively low coverage amounts. Previous federal rules limited these policies to 3 months in length. House Bill 2341 from the 2017 session amended Oregon law to match those previous federal rules. As the new federal rule does not preempt state law, short-term policies remain limited in Oregon to 3 months in length, with a restriction on renewals for 60 days. The division is currently reviewing the disclosures that are required to accompany these policies to determine if they need to be strengthened. And I can note that in the second quarter of this year, there were only around 3,000 short-term policies in force. Finally, in regards to association health plans, in June, the Trump administration finalized this new federal rule. It seeks to establish new, less stringent criteria to determine whether a group or association is a, quote, bona fide association under federal law by redefining the term employer in ERISA.
Importantly, the rule makes clear that it does not modify or otherwise limit existing state authority to regulate association health plans. And despite this lack of preemption, the department was concerned about the negative effects the new rule will have on Oregon's individual and small group markets. And in July, the state joined 10 other states and the District of Columbia in a lawsuit challenging the rule. And on September 10th, we issued a bulletin that summarized and clarified relevant Oregon law related to AHPs and informed our stakeholders that we will continue to enforce all Oregon laws applicable to AHPs as they existed prior to the issuance of the federal rule. I'll stop there and turn it over to Rick.
Thank you. For the record again, Chair Greenlick and members of the committee, I'm Rick Blackwell. I'm the policy manager at the Division of Financial Regulation. I'm just going to go through as quickly as I can some additional market stabilization efforts that we're working on with the division. First one, as Director Smith noted, we're working on finalizing the administrative rules for the Oregon Reinsurance Program. So as you know, the statute actually required us to develop rules to flesh out the reinsurance parameters, the attachment points, which is the point when reinsurance actually applies. The reinsurance cap is how much can actually be paid out on a claim under the program, and then the co-insurance rate is the amount paid against the claim on the deductible. So we actually met 4 times since April with the advisory committee that I think we have available on our website. I'll make sure to get Oliver some additional information for the committee. The August meeting, we rolled out the draft rules. Those are available still for public comment. We haven't yet filed those rules, but when we do, there will be essentially a 49-day period from the time we file and give you folks notice to the time those rules can be effective. So we are on the I guess the tail end of that rulemaking. Rules also talk about how to calculate payments, and then our administrative duties. Make sure to audit the claims coming in, making sure that we're paying out claims to eligible insurers, and then making sure that the parties understand what the reinsurance calculations look like. Another area that we're working on in conjunction, with assistance from a grant from the Centers for Medicare and Medicaid Services, I always get that wrong, I apologize, is the area of geographic rating areas. So before the passage of the Affordable Care Act, and to this day, Oregon has been split into 7 different rating areas, which are essentially county by county groupings where insurance is a little different. So essentially, premiums do vary between these rating areas. Carriers may cover all or part of a rating area, and so, but in the meantime, there's been a lot of demographic change in the state. Certainly the Oregon of the 90s does not look like the Oregon of today. And so what we're doing with this grant is engaging some actuarial work to determine if changes to those rating areas would actually net positive impacts for Oregonians on premiums and other availability of insurance and the like. So that work is going to be a multi-year process, but hopefully it'll help determine if coverage options can be improved. And so with that, I think
we're happy to take any questions.
Do you have a sense that the decline in medical trend that results in the lower requested premiums is relatively permanent, or do you think it's something unusual in the year, or the fact that the pendulum has swung too far in earlier years?
Chair Greenlick, thank you for the question. Medical trend is one of several factors weighing into the rate decisions. We do have the numbers for each of the carriers. We'd be happy to provide you on the breakdown of it. I wouldn't necessarily say that medical trend is decreasing over the years. The decrease in premium rates for 19 versus 18, 17, and 16, a large part of that has to do with the stabilization of the carrier's financial positions, the reserves, and also a positive impact of the reinsurance program, helping to keep rates from decreasing.
We need to talk about medical trend more. Vice Kenny Geyer, Then Representative Hayden.
I'm delighted to hear about the reinsurance high-risk pool working. I think that 6% is exactly what was estimated when we were considering it last year. That's great. I see that we have, at the end of this hearing, provider non-discrimination brought forward by the Oregon Chiropractic Association, and I've heard certainly complaints about it from that, as well as from behavioral health as providers, as well as from midwives and freestanding birthing centers. So I'm curious how you're handling those complaints and whether you're doing any kind of audit of that issue.
Chair Greenlick, Representative Kenny Geyer. So federal law does prohibit discrimination with respect to participation under the plan or coverage against any healthcare provider who is acting within the scope of that provider's license or certification. And it's something that we are under constant review of our benchmark plans, whether with chiropractors or larger behavioral health concerns. Where we don't feel as comfortable is weighing in on that actual providers when they are using the different billing codes that are set by national standard setting bodies. We would defer more to those to guide the decisions within the actual plans.
So a follow-up. So there are some plans that don't accept any, categorically deny, for instance, direct entry midwives. So that's got nothing to do with billing. It's just whether that can be a part of a provider network. So have you been hearing this? I hear this a lot. Are you hearing that? And do you have any plan to try to address that? My understanding is that our laws in Oregon are perhaps too vague, and that if we were more specific, that might help you, but I'm just curious about your perspective on that.
Chair Greenlick, Representative Kenny Geyer, I think network adequacy is always of a concern and under constant review, and we'd be happy to look further into what we have in terms of complaints coming in from consumers to our advocacy line and bounce those off of you and see where we can look going forward.
Thank you, Chair Greenlick. With respect to the 7 geographical multi-county locations for your insurance premiums, broad strokes, there's probably 1,000 different things that go into different insurances, but broad strokes, are those populations equally split between those 7? And if not, does a higher population correlate to lower rates or higher rates? I.e., is it more expensive in urban or rural?
Well, Chair Greenlick, Representative Hayden, the 7 geographic rating areas were set in the mid-90s or early 90s for purposes of small group reporting. The populations are not evenly distributed amongst them. One rating area is the Portland metro area. That's adjacent to another rating area, which includes Hood River and extends all the way to the eastern border. The rate changes between the areas. The Portland metro area would have the lowest geographic factor, and there could be differences of $70 to $90 between rating areas. And what we're looking at is how those rating areas could be adjusted in order to better reflect not only population areas but other factors that can contribute to rates. And one of those, and the complicating factor in that, is provider networks within geographic rating areas. And those are things we'll be looking at.
So just to recap briefly, the further you are away from a population base, the more expensive your health care. Is that a fair statement? The higher your premium?
Chair Greenlick, Representative Hayden, that's reflected in the rates, but we're going to examine whether or not, or what the connection between those two are, and if it is a purely because of geographic spread or just the types of providers or networks in the area.
Chair
We need to
Greenlick.
move on. You have a last comment, Mr.
Chair
Smith?
Greenlick, Representative Hayden, this study will also be looking at how do we further access in rural areas. Both Lincoln County and Douglas County, with one carrier on the marketplace, we're going to be continually looking at what expands that access throughout the state.
Thank you.
Thank you very much, guys. I'm sorry we have so restricted time.
Thank you.
You have a lot of interest in what you're doing. Ask the next group to join us. Representative Baez, Representative Fahey. Representative No.
Things I want to say after you're done, so we can
Okay. Sure.
Go for it.
Okay. Good morning, Chair Greenlick and members of the Healthcare Committee. For the record, my name's Rob Nose, and I'm the State Representative for House District 42, which is inner Southeast and inner Northeast Portland. In the 2017 legislative session, we passed Senate Bill 419, which created a joint interim task force on healthcare costs. Our primary directive was to study the feasibility of a hospital rate-setting model similar to what is used currently in the state of Maryland. The task force brought together many different stakeholders from the healthcare industry, along as senators and representatives. And after many months of meetings, we've released our final report. Our research and deliberations revealed that the Maryland model is not going to be workable for our state. But with that, we reviewed some alternatives, and I'm excited to talk about the one that we landed on. Just a little bit about Maryland's rate-setting program and why it won't work in Oregon first. They've had a federal Medicaid waiver that's been in place since 1977. That waiver allows them to receive a higher rate of Medicaid reimbursement, and that level of reimbursement props up their rate-setting program. Basically, in Maryland, every hospital procedure costs the same, regardless if the payer is Medicaid, Medicare, or a commercial health insurance plan. At this time, we think it would be very hard for Oregon to acquire such a waiver from the federal government. We also worry that rate setting would promote a fee-for-service model that might incentivize hospitals to have patients receive care in their setting rather than consider if another care setting is less costly. And even Maryland has that concern, as they've recently changed their approach to be more like global budgets for their hospitals rather than a pure rate setting and price setting process for each hospital procedure. A rate setting program would also be logistically challenging for Oregon to implement. We'd be setting prices for over 60 hospitals with lots of medical procedures in many settings, both rural and urban and suburban. With the Maryland model sort of disqualified as a possibility, we focused on 3 other policy solutions being tried in other states. Hospital global budgets, creating a statewide all-payer accountable organization, and an annual growth target paired with statewide benchmarks. And while none of these options are mutually exclusive, the policy option that our committee reacted to the most positively was the third one, an annual growth rate for healthcare costs. A statewide benchmark, similar to what Oregon's 3.4% rate for Medicaid and PEB and OEB has been. Specifically, an agency or a department of the health authority would examine healthcare costs and prices through a public reporting process and establish a statewide target for the annual rate of growth to control total healthcare expenditures in Oregon, just like they're already doing in Massachusetts. I think the concept is simple to understand. It's a little like a tuition cap, but obviously behind the scenes for the healthcare industry broadly defined, there will be a lot to this. Based on the report, in the 2019 session, legislation should come forward to ask the Oregon Health Authority to create an advisory board to draft another report and work out the details for eventual legislation that would consider the following: the scope of the benchmark. It's not just going to be hospitals, as it should include providers and insurance plans. The kind of agency or department within the health authority we would need, its budget, its staffing. How would we transition to this new model? What methodology we would use to come up with the benchmark, the revenue structure necessary to pay for the part of the health authority that would administer this new model, and an enforcement mechanism when healthcare entities can't or won't meet the benchmark. We believe that if the legislature follows the recommendations in the report and the health authority is given the resources it needs to develop this approach, and if enough of us agree, this new model for healthcare cost control could be up and running by 2022. Now, I'm going to go off script a little bit here, Mr. Chair, even though I have it actually written down in front of me. I believe that we need to do something. We can't just let the industry, broadly defined, continue to charge whatever it wants. And we need to include all segments of the industry, not just hospitals, though hospitals are certainly a big part of the cost, and looking at their costs was part of our original charge. For people who are leery about this idea, I would ask you to give the health authority a chance to figure out what it would cost to implement this approach and the staffing it needs, what kind of statutes we would have to enforce a benchmark, what sanctions would work, so that we can really debate whether or not this is going to be a good idea. There's going to be a lot of chances to question this more thoughtfully once we examine more closely how Massachusetts is doing it and how we might do it here. In the meantime, for those of you that are going to be around in 2019, I hope you'll support a bill that says, let's figure it out and employ some smart people to help us. I don't know if any of my colleagues want to add anything.
Yeah, sure, I'll go. I'm Representative Julie Fahey, State Representative for West Eugene and Junction City, and I just want to reinforce some of the comments that Rep. Nose made about why we ultimately decided that hospital rate setting wasn't necessarily a good fit in Oregon. We've made some really good progress in Oregon with transforming our healthcare system, and in some ways, I think a hospital rate setting system that sets a price for every procedure and every service would be a step backwards. When you set up a system that compensates someone for everything that they do, that creates an economic incentive for doing more things. And which is one of the reasons why in the Oregon Health Plan we compensate CCOs for managing the health and the care of their population, as opposed to every Tylenol that's dispensed in the hospital. And Maryland, as Rep. Nose mentioned, Maryland actually also came to that conclusion, and they have shifted towards a global budgeting model for their hospitals. On the concept of a healthcare benchmark itself, I agree with and support the recommendations of the task force, and I just think it's important to say that just setting a goal doesn't mean that we're going to see change in the healthcare system. Setting a benchmark is a necessary but not sufficient thing to do. I kind of liken it to setting our climate goals. They're important. I'm glad that we have climate goals. They tell us where we want to go and why, but they don't tell us how we're going to get there. So I see the healthcare cost benchmark as being a continuation of our work on our healthcare system, but not by any means the end point. As Rep. Nose mentioned, the other two approaches that we considered, some type of accountable care organization statewide and global budgets for hospitals, they're not necessarily mutually exclusive of a healthcare cost benchmark. So I expect we'll be continuing those conversations, and I also expect we'll be hearing more about greater price transparency for consumers and better information for providers about their costs and their prices and their utilization compared to other states. Q Corp has been doing some of that work, which is great, but expanding that would be nice too. So I hope this has been helpful. I think Senator Breyer wants to add some comments.
Thank you, Mr. Chair. For the record, Senator Lee Breyer. I think first I'd like to start by thanking Mr. Dropplers and Director Smith for kind of shepherding this process forward. It's probably, in my 20-some years around the legislature, is probably one of the most in-depth reviews of a problem or policy issue that I've seen. They did an extraordinary job, and the report's very good. And for those who want more detail, the stuff that's on the website having to deal with that is pretty extraordinary in terms of looking what other states are doing and that. I don't completely agree with Representative Nose on the regulatory side. Not a big surprise, since I spent a decade as Oregon's chief utility regulator. I do think it's possible to do that. But clearly, I believe in practicing the art of what's possible, and that's not possible at this point, in my opinion. The other good thing, or the other thing about this approach, is we had a large panel of people who are experts in the area. One of the things that I suggested when we created 419 is not just stick a bunch of legislators on it who really don't understand what they're talking about. Well, let's get some pros in the room to have this discussion. And I think one of the things that's unique is the report that you will be receiving was endorsed across the board by those in the profession, and it includes the full gamut from insurance companies to providers. So I think it's a pretty good document. I think it moves us forward, has the opportunity to move us forward in gaining some control over healthcare costs. It focuses the attention on the increasing there, and the reporting structure, if we adopt what the two states that are moving there, Vermont and Massachusetts, if we do that, I think it adds an element of transparency so the public can see what's going on, and it puts a little pressure on providers to keep their costs constrained, as we tried to do in the last session with pharmaceuticals. So I think it's a good process moving forward. I don't think it's necessarily going to cost a lot of money. I think through the Health Policy Board, we already have a structure in place that can be adapted to do that, and will provide future decision makers with much better information, and I think it'll put a little weight on cost increases and will help us move. And I hope at the end, quite frankly, my bias is I'd like to see us move over time to a single payer system. Tomorrow would be soon enough for me, but that's not going to happen. So thank you, Mr. Chair. Happy to answer any questions with the panel. And if there aren't a lot, I've got a committee to run that I got to get back to.
Yeah, thank you. I won't hold you up too long, but I commend you for reaching the conclusion that the Maryland model is not viable for Oregon. As Rob knows, I raised a lot of question about the Maryland model from the very beginning because of the special deal they have with the federal government. And it's compelling to see you want to limit, have a benchmark with regards to cost increase for hospitals. My question would be, are you proposing also to hold labor costs, specifically ask the Oregon Nurses Association, SEIU, to cap their benchmark at 3.4% for wage and benefit increases?
Mr. Chair, Representative Buehler, I want to correct a point. It's not a benchmark for hospitals. It's a benchmark for healthcare across the system, and certainly that would put pressure on labor, since that's a big cost.
I think the interesting thing about this idea, Chair Greenlick and Representative Buehler, is that it's going to ask all these entities to manage themselves to the benchmark. So no, we don't contemplate that contract that would be worked out between the hospital and one of its bargaining units would necessarily limit itself to a 3.4 increase or whatever rate we eventually decide on. But that's certainly going to be one of the factors that impacts that. It could be the same for executive salaries or what orthopedics made.
We should all, if we're all going to play at 3.4, I'd expect all labor to play at 3.4, but that would be very interesting. It'd be a great benefit for the state of Oregon.
We could voluntarily hold our wages to that. We're going to have to end this. We'll have plenty of time to talk about it. I assume there's a bill coming forward. Do you know what? Have you decided whether it will be in the House or the Senate?
Their chamber's going to start it.
Pardon me?
Senator Byers going to start it off.
Good.
Not even then.
Happy
Thank
to
you very
discuss
much.
that further, Mr. Chair.
What is our right? What is our
I'm going to ask.
Totally.
We're going to have, I think, Multnomah County now. Is that right? Yes. Dr. Myron, will you join us? Some members of the committee have asked that we take a 10-minute break. Come on. A 10-minute break exactly at 10. So your 15 minutes are going to be limited very strictly. So make the most of it. And the break will be 10 minutes, limited very strictly. We'll be back at 10 after 10. We'll adjourn at 10. Recess at 10. Dr. Myron.
Thank you. Good morning, Chair Greenlick, Vice Chair Hayden, and members of the committee. Thank you so much for providing us with the opportunity to present this morning. My name is Sharon Myron. I'm a Multnomah County Commissioner and also a practicing emergency physician. My co-presenter, Dr. Rachel Solotaroff, is the Executive Director of Central City Concern, and we will be giving you a brief overview of the Mental Health Systems Analysis Report and research process that Multnomah County undertook this past year, and we will discuss in particular some of the recommendations and actions that we've identified to carry the work forward. Before we begin, I'd like to hand it over to my co-presenter to introduce herself.
Thank you. Chair Greenlick, members of the committee, thanks so much for having me here. I wanted to give a 10-second overview of Central City Concern, which informs my comments this morning. Central City Concern is a broad-based social service organization in Portland and Multnomah County and Clackamas County, whose mission is to provide comprehensive solutions to ending homelessness.
Your name, please.
Sorry?
Your name?
Oh, sorry. I'm Rachel Solotaroff. Thank you. We serve about 11,500 of the most vulnerable members of Multnomah County. And what is distinguishing about our staff in particular is that they are made up of about 50% of them of people who have lived experience of homelessness, of substance use disorders, of mental health conditions, and that informs the work that we do. We provide over 2,000 units of affordable housing, health care inclusive of mental health, substance use disorders, and addictions care, as well as supportive employment. We've had a long and rich history with Multnomah County, both through Medicaid contracts and general fund, and supporting everything from outreach-based services to residential to outreach service or to outpatient services for our members. I will say I'm a primary care physician by training with a subspecialty in addictions medicine and pain management. And I spent the first 15 years of my career advancing the concept and practice of the patient-centered primary care home in Oregon, where I can see its enormous benefits. And I think the time has come to apply the same type of structure, of rigorous standards and payment methodology to behavioral health that we've applied in primary care. I'll be speaking about that a bit more.
So, by way of some very brief background, about a year ago, Multnomah County contracted with an organization called Human Services Research Institute, or HSRI, to do a deep systems analysis of how mental health care is provided and perceived throughout Multnomah County. I wanted to do this study to create a shared understanding of a very complex system toward the aim of pursuing meaningful change. As I'm sure many of you can relate to, mental health care is such a big, complicated, and multifaceted system, like a gigantic knot, and it's challenging to know where to even begin to pull the first thread to begin to unravel the knot and figure out where to direct our further effort toward improvement. But we have to begin somewhere. I felt that establishing a baseline, this shared understanding of how things look now, would be a natural first step toward identifying areas for change. HSRI was tasked with researching and reporting findings on a range of financial, demographic, and qualitative aims related to the way that the current system of mental health care exists and is experienced, most importantly, by the people in Multnomah County. That last part, like I said, is one of the really important principles HSRI delivered on. Centering my voice is disappearing, so I'm sorry, it's like going away as I speak. Centering the voices of people with lived experience. We didn't want to just know what we're delivering or what we think we're delivering, but how people are experiencing it. HSRI paired quantitative and qualitative data, remaining an objective, expert, third-party witness or validator of findings, many of which are not new or surprising to people working in the field, but it's really good to have that third-party external validation for what many of us know working in that system have known for years. HSRI completed the research in May. They finalized the report in July, and overall, the report found a huge disconnect between the system's aims, sort of what we as a system perceive that we're providing, and how the system is actually experienced by those who are using it. The disconnect is at the root of many of the key findings of the study, and resolving it is at the root of some of the report's recommendations. So, there were 3 priority recommendations made in the report, along with a number of other sort of sub-recommendations. We're going to focus on those 3 priority recommendations right now. The first is create a shared vision for the mental health system in general. And that sounds kind of broad and froofy, but it's not just a mission statement. We all have mission statements. Everyone has that written down somewhere. But this is larger. Mental health care is way more than the county oversees. It's bigger and suggests something that a broader range of entities and stakeholders are held accountable to. Second, create a director-level lived experience position. Multnomah County has a number of individuals in and outside the health department and the mental health services division who identify as having lived experience as consumers, peers, or family members. I include myself as one of those people. But this recommendation is really about elevating the value of lived experience by making it the core of someone's job. So At the policy-making level, they will have lived experience sort of focusing what they do and what they contribute in a leadership position at the county. Finally, the third recommendation revolves around understanding how funding flows through the system, which it's really difficult to see through that opaque sort of window of how the system is funded, how reimbursement mechanisms work, and also improving data integration and analysis. This will allow the targeting of future improvements and outcomes. So this is admittedly a broad recommendation and will take a lot of work, a lot of potential future actions as we explore this more widely. So, operationalizing some of these recommendations may help provide some opportunities for state action, which I will speak to a bit later on during the presentation. The report also highlighted some important themes that show up, and I wanted to just call out two of those. The first is workforce. We know workers across the system are often underpaid and overworked in unbenefited or underbenefited positions. They have high volumes of intense caseloads and don't always receive adequate training, supervision, and support in their jobs. If you wanted to speak briefly.
Yeah, I mean,
to
my
that.
concern with this is that this often affects staff with less professional training, such as peer support specialists, qualified mental health assistants, and certified alcohol and drug counselors. They, given the situations that the commissioner described, these folks can be pulled into situations of managing large caseloads with high complexity and providing a level of service for which they're not trained. This can put both our clients and our staff at risk. I've heard a lot of wonderful conversation about the use of peer support specialists and peer mentorships this morning, but I want to ensure that in doing so, we understand that peers must work at the top of, but also within their license. What peer support is excellent at is engagement, navigation, and good common sense. This does not include things like case management, counseling, and crisis response, which they're often drawn into if the rest of the workforce isn't adequately staffed and engaged. Finally, we hire many new clinicians, particularly in the safety net system, right out of school. Many of them did internships and practicums with us, and they gain brass tacks and real-world experience in our organizations. But then they often leave after 2 years, after getting some on-the-ground training for other jobs in higher-paying non-safety net systems.
So, the second major theme that ran throughout the study was, and this was like a reflexive response, we would mention mental health care, what are barriers, and this theme was housing. Many of the services and interventions we provide are not as effective or are entirely ineffective when someone doesn't have housing. And for many people with complex needs, housing is enormously tricky to get and to keep. This report makes it absolutely clear that we need more supportive housing to improve outcomes. And that is, as I'm sure you all know, but that is the affordable housing with the wraparound services available so people have services where they are. Multnomah County and the City of Portland have jointly committed to creating 2,000 new units of supportive housing in the next 10 years. And we have some really promising things on the horizon, including projects already in the pipeline, as well as opportunities like the Metro Housing Bond that could help address the capital side of producing units. But we really need to work aggressively now on identifying how to pay for the services, which are key to pair with the housing itself.
And I would just point out that in addition to improving outcomes related to mental health and substance use disorders and improving housing retention, these supportive services and housing also save money in the healthcare system. An internal study within Central City Concern looked at individuals who got outpatient behavioral health with supportive housing compared to those folks who got outpatient behavioral health without supportive housing. And the former category incurred 1/3 of the behavioral health cost and 1/3 of the total health care cost of those folks who didn't have the supportive housing. So we have an opportunity to really align and leverage our behavioral health and housing investments to increase our return on investment and decrease costs in the healthcare system.
I do want to mention just two two other themes, just a sentence each, and one relates to addressing the disconnect in reimbursement and payment between mental health and virtually all other systems of care. So particularly substance use disorder, the so-called dual diagnosis, but also if someone has a mental illness and any other like complex medical need, traumatic brain injury, dementia, so many other coexisting medical conditions. Additionally, a pervasive issue that came up was the lack of culturally responsive or specific services throughout the entire continuum of care. So, what do we do with all of this? And this is what we're focusing on at the county, where you might be able to focus as well. We're pursuing both immediate and short-term actions. For example, working internally on exploring the possibility of having a peer leadership position at the county, while we develop the longer-term strategy and structure for sorting through, prioritizing, and implementing the longer-term recommendations. Part of this is working with the legislature in 2019 to pursue some key policy and funding goals that begin to respond to recommendations in the HSRI report. So when we set out to do the process, we wanted to be very sure we didn't do something that just sat on a shelf like so many reports do with the best of intentions, or wait until we had all the pieces perfectly in place and aligned before we took any steps. So we're committed to acting, learning, revising, and forging ahead thoughtfully. So there are three particular legislative concepts or general policy buckets, look at the time, that Multnomah County will be actively working on. The first is creating and providing a standard of quality, predictable behavioral health care within CCOs. And that's something right now that doesn't seem to exist, this shared, consistent standard across the system. And a start to gleaning that will be getting that collaboration with the stakeholders and getting a clear standard of care within CCOs.
Maybe I'll just jump in. I think this would be a great opportunity, again, to look at the success of something like the patient-centered primary care home model.
We're done.
Okay.
We got 2 more minutes on there.
Well, the clock is
late. Oh, is the clock slow? Okay. Well, happy to talk to any of you offline.
I hope you're linked to the state's plan for working in the metropolitan area as well.
Yes.
Thank you very much, and thank you for being so safe. We are adjourned, and we will start back to order.
on the 26th
We've got
of October.
The reps aren't here. I mean, the R's aren't here.
We've got 15 minutes scheduled
Oh, isn't that funny?
Coming
for
to
this
his house. I
presentation.
can't go because I'm going to be gone.
Where are the R's?
Take a couple minutes less, that would be nice too.
So.
Where all the D's are back?
Yeah, shh.
Please introduce yourself.
Good morning, Chair Greenlick, Vice Chair Hayden, and members of the committee. I'd like to thank you for inviting me to be with you here today to talk about adverse childhood experiences, trauma-informed care, how this is the current interventions and challenges in the healthcare system. And this is really more a 40,000-foot view. Again, my name is Dr. Terry Pedersen. I'm a pediatrician by training. I want to be very clear that even though I've worked with different organizations and for organizations since my retirement, these are my own personal opinions. So I'd like to review the results of a study that came out of Kaiser in San Diego in the 1990s, where they asked over 17,000 Kaiser adults about their own personal experiences of abuse, neglect, and growing up in a household with major dysfunction. And what they found from that, it was not surprisingly that children who experience trauma are more likely to adopt later high-risk health behaviors and have poor health outcomes, regardless of whether they have high-risk behaviors or not. And they even did this, figured out a way to represent this numerically, where they looked at the number of types of adversity that people experienced, and they gave them scores accordingly. So they came up with 8 scores of people, and this is a graphical expression of that, showing what happened if they looked at smoking as a potential health outcome. That they saw that people who have an ACE score of 0 on the left-hand side much less likely to be smokers than people who have an ACE score of 6, for example, or 6 or more. And the ACE scores range from 0 to 10. And what they found was that no matter what the health outcome they looked at or the health behavior that they looked at, that every single one of them had this, what we call a dose-response curve, what I call a fascinating stair-step graph. The higher one's ACE score, the more likely one is to experience these things, including real surprises to even the people who are doing the studies. Increased ER visits, increased medical office visits, increased hospitalizations, increased fractures, and increased risk from early death from a heart attack. And that in fact, that was the highest risk thing, was having adversity in childhood. That was the highest risk behavior for having a heart attack later. But epidemiologists also say that what is predictable is preventable. And so if we think about all of the prevention programs, I think about all the prevention programs that I had as a pediatrician, they were all pretty isolated. We had individual programs about smoking prevention, teen pregnancy prevention, substance abuse prevention, and a lot of things to try and prevent heart attacks in people later on. What the ACE study tells us is actually if we can prevent child abuse and neglect, we have an underlying potential cause for all these things, and if we could address abuse and neglect, we would be changing health outcomes. So how does this align with current goals? It is perfectly in alignment with the triple aim of improving overall health care, improved perception of health care, and decreased cost. In addition, it meets the quadruple aim because clinicians who are able to adequately address this challenge feel that they feel more fulfilled in their practice. And even though you guys this is the healthcare committee, the other things that will affect is that it will improve school performance and decrease dropout rates. We'll be able to decrease our homeless population, a very complicated issue, but this will also have an impact. It will decrease incarceration rates and decrease suicide rates. So it aligns with many, not only healthcare goals, but many goals that the state has. So how are clinicians addressing this? It tends to be very, it's kind of a smorgasbord of how people choose to address this. There are a number of groups who are saying, pediatric groups and family medicine, who are saying, well, if I can identify the parents who are most at risk because I identify what their ACE scores and their resilience scores are, I take their trauma out of the closet, I agree to support them in ways to basically change the intergenerational transmission of trauma, it makes a difference. There are those who say, no, that sounds too difficult for me, I'm just going to focus on resilience, I'm going to promote resilience, and there are a large group of pediatricians in the Portland and Salem area who are doing this. Other groups say, no, we know if we focus on social determinants of health, food insecurity, diaper insecurity, if parents are less stressed, their children are less likely to be abused and neglected. We're going to address that. Others say, no, our population is so high risk, we're not going to ask any of those questions. We're going to assume everyone has high ACE scores, low resilience, we're going to improve our own communication, and we're going to work from that way. And we're also going to use peer supports to help people. There are 3 large systems that are using the Oregon Family Wellbeing Assessment, which came out of the Oregon Perinatal Collaborative, that it is the most comprehensive assessment of pregnant women that I have seen, and it identifies many risk factors for women who are pregnant, agrees to support them, again, in the ways that they need it, and I think we're going to see some pretty amazing results from that. Other people have said, no, actually, I'd like to work with the kids who are most challenged, the kids who are already in our foster care system, and develop a medical foster home, a primary care home for these kids who are in foster care. So those are some of the things that people are doing. I'd like you to know that also people are looking at this in other ways. Opal K, for example, thank you very much for that funding, asks every clinician who calls, do you think trauma might be an underlying cause for this child's symptoms that you're calling about? So hitting it from many directions. The challenge is, I think that preventing child abuse and neglect has not necessarily been a focus of healthcare promotion historically. Also, that our CCOs function very independently, very much on purpose, but it means we're getting quite a piecemeal approach to how we should approach this, and that each community also has its own strengths and challenges, which is why we have the CCO system as it is. At a practice level, medical practice is very protocol driven these days, and we don't have a good protocol of how to think about trauma. There's a perceived lack of time. I have so many things I need to do. Why are you asking me to take care of this as in addition? People feel they weren't trained to do this kind of work. And I've had people tell me, you know, the CCS have so many metrics. I have so many things I have to do. This is not a metric, and you're asking me to do it anyway. I think that one does get in the way as well. So even though there's no specific ask here, I would ask anytime you have the opportunity to prioritize child abuse and neglect that you do so, and in addition to promote attachment and early relationships, because we know that also makes a huge difference in health outcomes. And whatever approach gets taken, that it be at least a 2-generation model. So thank you, and I'll hand over to Patrice now.
Thank you, Doctor. Thank you, Chair Greenlick, members of the committee. My name is Patrice Altenhofen, and I'm the board president of the Oregon Association of Relief Nurseries, and I also serve as the executive director of Family Building Blocks, which is the relief nursery serving Marion and Polk counties. The goal of the relief nursery model is to prevent child abuse and neglect and to promote healthy social and emotional development of children considered the most vulnerable in our community. The impact of the model is that children stay safe, they stay out of foster care, and are able to continue living safely with their parents and families. There are 31 relief nurseries statewide, collectively serving over 3,000 children each year. 9 new communities are ready to establish relief nurseries in the coming biennium. Places like North Roseburg, Woodburn, Klamath Falls, Toledo, Willamina, The Dalles, and East Multnomah County. There are 10 factors measured by the ACE score. 5 of those are related to child abuse and neglect. And we know that child abuse is intergenerational, meaning that if a parent has suffered abuse and as a result has a higher ACE score, their child is at risk for abuse and sadly a higher ACE score as well. As the doctor explained, 75% of Oregonians have 0 to 2 ACEs. And while we have just scratched the surface on collecting ACEs data at the relief nursery families, we do know that at one of our largest relief nurseries, the average ACE score for parents is 6, which can translate into a 20-year shorter lifespan. And the most recent evaluation for relief nurseries, we found that our parents experienced the following ACEs. 47% were raised by an alcoholic or drug-affected caregiver. 45% were victims of childhood abuse. 34% lived in a household with an incarcerated parent. 77% of families reported being un- or underemployed. 46% cannot provide enough food for their family, and 46% experienced domestic violence. We cannot change what happened to these parents as children, but we can directly impact what the child experiences with this parent. And by partnering with parents to stop that intergenerational cycle, we directly address the exposure of children to adverse childhood experiences and support long-term health outcomes. Relief nurseries include therapeutic classrooms, home visiting, parent education, as well as wraparound services like respite care, clothing closets, food pantries, and diaper banks. We are the ideal setting for children who are facing tremendous stress at home, healing from trauma, or experiencing developmental delays. Let me tell you about Kyler and Melanie, a mother and son who were on the brink of disintegration due to factors making it very likely Kyler would suffer from abuse and neglect. Kyler was born 2 months premature, weighing only 2 pounds at birth. He faced significant health and behavioral challenges, and when he first enrolled with Family Building Blocks, he had extreme sensitivity to noise and new environments and was overstimulated and unable to regulate his emotions. He cried constantly and did not interact with teachers or other children. Kyler also has very limited verbal capacity. At the same time, Kyler's mom, Melanie, was struggling with severe depression. Melanie lost her first child, Leland, when he was 17 days old. We know that moms suffering from depression often have trouble bonding with their babies, and this was true for Melanie. Melanie now uses the time that Kyler spends at the relief nursery for self-care and respite. And through home visiting, she's learned techniques to calm and soothe her son. And Melanie has said, without Family Building Blocks, I would still be lying in bed. Kyler's classroom teachers partnered with Melanie to address Kyler's needs. They agreed that Kyler would arrive to class 15 minutes early so that he could adjust to his surroundings and regulate his emotions. And our mental health consultant provided additional supports in the classroom and referrals to occupational and speech therapy. Today, Kyler no longer needs to arrive to his therapeutic classroom early. He rarely cries, and he eagerly plays with his classroom friends, using sign language and verbal cues to communicate. His progress in 6 months has been described by our mental health consultant as truly remarkable. Living with a parent who experiences depression is an ace. Mental illness is the 4th most common stress factor leading to abuse and neglect, preceded only by alcohol and drug use, domestic violence, and parental involvement with law enforcement. Having a child with a disability is the 11th on the list of stressors for families with founded abuse. I am here in front of you today to offer a reminder of the connection between quality early childhood experiences and health outcomes. And it's not that difficult to understand that a small child who suffers abuse is less likely to be successful in kindergarten and more likely to end up in the juvenile justice system. But it really seems unimaginable that a child who suffers abuse is at greater risk for adverse health outcomes long term. ACEs shows us that this connection is very real and very strong. So simply put, a significant portion of the billions of dollars spent on healthcare in the state of Oregon is due to what happens or doesn't happen to children. Thank you.
Thank you very much. And thank you for the great work you do. We all recognize how important it is.
Thank you.
Thank you very much for bringing this to our attention.
Thank you.
We have the next panel, please.
We have Zini Junkir and Clarice Amorim Fritas.
Should I start? All right. Well, good morning, Chair Greenlick, Vice Chairs, and committee members. We thank you for your time provided today for this discussion about the Regional Health Equity Coalitions. My name is Clarice Amorim Freitas, and I'm the coordinator of the Lean Benton Health Equity Alliance, a project of Willamette Neighborhood Housing Services. Our coalition is one of 4 regional health equity coalitions in the state of Oregon. And our coalitions are also community-driven, and they build on the strengths of local communities to work toward long-term policy, system change, and environmental changes to increase the health equity for communities of color and other marginalized identities. Some of our work started long before our coalitions had financial support from the state. However, since the Oregon Health Authority started funding our coalitions back in 2011, we have been able to increase our capacity and to better serve our communities. Currently, there are state-funded coalitions serving the following Oregon counties: Lean, Benton, Hood River, Wasco, Multnomah, Washington, Clackamas, Jackson, and Josephine. There are also new regional health equity coalitions being developed in Malheur and Umatilla in eastern Oregon, as well as in the Confederated Tribes of Warm Springs. Collectively, we serve 57% of Oregon's total population, 57% of Oregon's Medicaid population, 53% of Oregon's communities of color, and 60% of Oregon's Latino communities. In order to tell you why our work is meaningful for the community, I would like to spend some time talking about the history of grassroots community engagement and leadership development in Lean and Benton counties. Our coalition is one of the oldest of its type and has been around for at least 10 years. What started as a truly grassroots effort on the part of interested community members has evolved into an organized effort of partners across sectors who care about the needs of our most vulnerable community members. Currently, among our member organizations, there are some pretty big players, such as the local Coordinated Care Organization, Samaritan Health Services, and Oregon State University Extension Services. These powerful institutional players share decision-making in the coalition with very small, nonprofit, often volunteer and grassroots organizations. We're talking here about a local parent-teacher association that serves a very diverse elementary school. The local chapter of the NAACP, small nonprofits that serve Latinos and rural families in Lean and Benton counties, and other volunteer-based organizations. I list the background of these organizations as a way to demonstrate how we are building cross-sectional partnerships between unlikely partners that work in housing, healthcare, social services, education, and government. This is one way in which our existence as a coalition has allowed organizations large and small to better serve our communities. On a more personal note, I have been in my position as the coordinator for the Lean Benton Health Equity Alliance for the last 2 years. I'm an immigrant in the United States, and when I was offered this job, I had been in Oregon for just over 4 years. At that point, though I had been pursuing a graduate degree in the field of public health and I had learned about health promotion and health behavior, I knew very little about how these academic concepts applied in the real world to build healthier communities. And even though I had a lot of education, even I didn't feel like I belonged in the decision-making circles of my city or county. Being part of this coalition allowed me to see community leaders in the making in action. Some of our longest-standing members have become known community voices for health equity and for marginalized communities. Over the last 2 years alone, I've seen our members change the way they talk about the role of their organizations in supporting health in communities. I have seen coalition members take and thrive in positions at community advisory boards within schools, hospitals, and government. I have seen our coalition members, through intentional capacity building, work to improve their understanding and their ability to talk about really complicated issues, to talk about social justice and racial equity and intergenerational trauma. Collectively, we have become a reference for local government who wants to understand the needs of communities of color in Linn and Benton County. And we have all learned how to offer that feedback in candid yet honest ways, honoring our truth and holding local institutions accountable for their priorities and their choices. Just in the past few years, we have organized, trained, and supported a network of community advocates that have become a constant presence in city council and county commission meetings, where decisions are made about housing, health, and education in our region. As a result, our coalition has been instrumental in organizing advocacy efforts in favor of passing a property maintenance code in the city of Corvallis that protects the needs and rights of tenants, and in favor of strengthening local tobacco retail licenses to protect vulnerable youth from predatory tobacco marketing practices. This kind of authentic community engagement and leadership development does not come easy, and it does not come fast. It takes years to get people who never felt like they belonged in decision-making spheres to develop the skills and to harness the courage to make their voices heard. It is invaluable work for marginalized communities, and yet there are very few resources out there to support this kind of work. We at the Linn Benton Health Equity Alliance know that we wouldn't be able to do our work without the support of the Oregon Health Authority through the Office of Equity and Inclusion and the Health Promotion and Chronic Disease Prevention section. And we truly appreciate the opportunity of letting you know how meaningful that support has been for us over the last several years. And Alzina.
Wonderful. Good morning, Chair Greenlick, Vice Chairs Hayden and Nose, and committee members. My name is Dr. Xenia Junkier, and I'm the director of the Oregon Health Equity Alliance. I want to thank you for the time provided today for this presentation. The Oregon Health Equity Alliance covers Multnomah, Washington, and Clackamas counties. As a resident of Multnomah County and someone who grew up in Washington County, it's an honor and a privilege to work alongside community members. My experience as a provider has been that patients are skeptical of the healthcare system due to a long history of inappropriate and harmful treatment at the hands of providers. The stories I hear from patients are heartbreaking. Patients who are made to feel like they have no voice, no power, and no say in their own medical treatment. Patients who relay their symptoms only to be mocked, shamed, and/or told that they don't truly know what they are experiencing. Seeing children whose parents are categorically excluded from health care coverage in Oregon, who are expected to care for their children and families and to work to make a living while not being able to see the doctor when ill. I've seen patients struggling with suicidal ideations and chronic depression who cannot afford time off work to care for themselves. I hear from colleagues who treat children who have diseases once only seen in adults, who have no safe spaces for physical activity or access to affordable, healthy foods. I share this with you as a way to uplift the importance of reevaluating our systems of care, including how we provide care, offer resources, and understand health and health care. It's clear we have made great strides in Oregon. It is also clear we have much work to do. And this work must center the voices, experiences, and solutions of individuals and communities most impacted by health inequities. For the Oregon Health Equity Alliance, this means we transform the ways in which our communities of color are engaged in the decisions that affect their lives every day. We do this in part through advocacy at the local, regional, and state levels, and we do this through direct engagement as well. Community-powered change is one example of this work, born out of our work leading the Multnomah County Community Health Improvement Plan. Community-powered change is lifting community voices to build the future we want to see, defining health equity for ourselves, transforming the ways in which community members engage with institutions and organizations that create policy changes, and creating healthy communities by dismantling racism at every turn. We want to create a space where health equity is valued and practiced by everyone. We leveraged these values when we fought for the Reproductive Health Equity Act in 2017, and the same year, OHE was integral in the passage of Cover All Kids, or OHP Covers Me. engaging constituents, community members most impacted, and allies to ensure that no child in Oregon has to miss school because of an illness that they were unable to seek care for. This is a prime example of how health care impacts more than just health and why it is so important for the regional health equity coalitions to work on the social determinants of health framework. It is a reminder that we still have thousands of adults in our communities who cannot access health coverage due to restrictions based on their country of origin. And even for communities who have coverage, lack of representation of providers who reflect communities they are serving and providers who provide culturally responsive care continues to keep us from equitable health outcomes. In the coming year, OHE is continuing our work to mitigate and address the social determinants of health. As part of public health modernization efforts focused on communicable diseases like hepatitis A and latent TB, we will once again be engaging our communities, prioritizing youth in the creation of policies around tobacco use that come from communities who face shortened life expectancies and chronic health concerns due to the use of tobacco and alcohol. OHE will engage in work to ensure communities understand the disastrous effects of opioids on our communities and to identify community-led opportunities to address this public health emergency. And finally, we have been following CCO 2.0 closely. We are excited about the opportunities and critical of how community voice was and will be used to ensure policy options will have the greatest impact, especially for communities of color who still face glaring health inequities. We wouldn't be able to do our work without the support of the Oregon Health Authority through the Office of Equity and Inclusion and the Health Promotion Chronic Disease Prevention Program. Their belief in OHE and the other regional health equity coalitions to engage in work that is driven by community members themselves has allowed for the amazing work you have heard about today. I don't like to talk about our work in terms of return on investment, as it seems disrespectful to the people we serve, who deserve our work and our support no matter what the return is. However, to make this point, I will use that language. With all the millions, perhaps billions of dollars spent on health, education, transportation, social services, etc., the just over $1 million shared across the 4 regional health equity coalitions and the 2 capacity building sites is clearly a very high return on investment, or yields a very high return on investment. Again, I thank you for your time. I know that it is limited, and I appreciate you hearing from us today. I'm happy to provide you with any additional information about our work, and I welcome you to come to our office or any events that we are hosting. We want to work alongside you to support bringing to the table the voices of Oregonians most impacted who are unable to be here today. This model of regional health equity coalitions is innovative and has opportunities to be replicated all across the state. Let's continue to lead the country, not only in healthcare access, but also in moving the dial on health disparities and creating the conditions for the best Oregon possible. Thank you.
Thank you very much. Representative Alonzo Leon.
Thank you, Chair. I just want to say muchísimas gracias. Thank you so much for the work that you're doing. It's an area that I'm very passionate about, as you all know. Making sure that 100% of our population in the state of Oregon gets the medical treatment that they deserve with dignity. But it takes all of us working together. It takes understanding different lenses and different perspectives and different styles. And I'm excited for the work in the CCO 2.0 because we need to make sure that we continue to work with all of the equity, all of the regional health coalitions around the state. And we don't have them represented in the entire state at all. And to me, that's a concern because that means that we're missing out on voices in different parts of the state, in the rural communities particularly. So I want to make sure that you know that I'm here to support those efforts. And you know, you're right. It's disrespectful to talk about ROIs because we're talking about human beings. But for most people to understand, that's how we do need to talk about it. We don't talk about it that way in a cultural perspective. So I appreciate your presentation, really powerful, on point. You made every point that I've ever wanted to make to the legislative body. And we need to continue to invite you to continue to reinforce that information because one invitation is not enough. So thank you for your work. Really appreciate it. Thank you.
Thank you, Representative. Thank you all. Keep up the great work. We do appreciate it.
Thank you very much.
Thank you very much.
Can we have the next panel, please?
Jeff Rhodes.
It's an easy panel.
Yeah.
Easy panel.
Chair Greenlick, Vice Chairs Hayden and Nose, and members of the committee. My name is Jeff Rhodes. I'm a Senior Policy Advisor for Governor Kate Brown on opioids, OLCC, and gaming. That includes the Oregon State Lottery and the Racing Commission. I'm here today to give a very brief update on the work of the Opioid Epidemic Task Force, which just held our 10th official meeting last week. And first, I just want to give a quick review of who we are and our charge. And in the interest of time, I opted to forego a usual PowerPoint, but I believe you all have a document on the dais that I'll reference in just a little bit here. We were convened in the wake of the 2017 session, and our mission is to put forward innovative policy solutions to combat the ongoing opioid epidemic. Importantly, we are a bipartisan and bicameral group that seeks to build consensus around our legislative recommendations. And in addition to legislative representation, we are comprised of doctors, pharmacists, treatment experts, government officials, and many, many others. And I must say it's been a privilege to serve with this highly motivated and incredibly talented group of individuals. It's just been a privilege. In 2018, the task force brought forward to this committee House Bill 4143, and that bill had three component parts, just by way of reminder. The first was a creation of a 4-county overdose prevention and peer mentorship pilot program. The second was a piece that required mandatory registration for the prescription drug monitoring program. And the third was a commissioned report from the Department of Consumer and Business Services examining barriers to accessing appropriate treatment here in Oregon. This bill, I'm pleased to say, was passed unanimously through both chambers and signed by the governor on the 27th of March, 2018. So today I want to report to you on the progress of that legislation, and I'm pleased to say the results have been overwhelmingly positive. I'd like to start first with an update on the prescription drug monitoring program and reference the document you all have on the dais up with you. In that report, you can see a sharp uptick as a result of House Bill 4143, which represents an increase, a sharp increase in the number of registrants for the program. At the second quarter in 2018, there were 22,834 registered system users, and as of August, this system already had 27,156 registered users, representing 72.2% registration. And I think it's really great to take a look at the visual that you have, because you can see that sharp uptick, which corresponds directly with the implementation of House Bill 4143. What might be more exciting, though, than the registration is the fact that we're also seeing a corresponding increase in the use of the system, which is something we didn't require in that legislation. During the same period, we experienced more than 6 times the number of queries to the system that we had in 2012, which is certainly encouraging news. Now, this isn't just attributed, of course, to House Bill 4143. We're also undergoing a huge monumental effort to integrate the prescription drug monitoring program into our electronic health records, and certainly this corresponds with that effort as well. As for the DCBS report, I'm also pleased to report that Rick Blackwell and his team, they worked very closely with the Oregon Health Authority to compile a comprehensive report that met all deadlines and, dare I say, exceeded expectations. A fantastic report that I encourage everybody to take a look at. In the wake of that report, Mr. Blackwell has been attending our meetings, gave an overview for the membership, and we're looking to take action on a number of those recommendations as we look to craft our 2019 legislative agenda. Lastly, we are moving forward with the crafting of the peer mentorship and overdose prevention pilot program that I mentioned. We've hired for the position within the Oregon Health Authority, the coordinating position, had meetings taking a look at the criteria and looking to get the money out the door very soon. So I look forward for further updates there, but things are progressing nicely. So very quickly, what does the future hold for us? As I've said to you in the past, we're in this for the long haul and certainly recognize that this work takes time and cannot be accomplished in one legislative session. Our group has been conducting comprehensive whiteboarding and matrix exercises, taking a look at our 2019 agenda, and as you can imagine, there is much to do and much to examine. One of the things that we are very interested in is a declaration of addiction as a chronic illness. One of the interesting statistics I've seen recently compares the relapse rates of addiction to that of hypertension and diabetes, and what we find is they're very similar. It's quite interesting. Yet we continue to treat treat addiction as a acute episode rather than a chronic illness, and that's something that we're taking a heavy look at and how we can make an impact in that arena. Of course, as I've said, we're looking very closely at the recommendations in the DCBS report, which are legion, and some can be accomplished legislatively, some can be accomplished via our agencies, some with the help of stakeholders, and we're breaking everything out and looking to put everything in the appropriate buckets there. We're also examining treatment standards of care, looking to raise those standards potentially through a certification process that recognizes the importance of the work, but at the same time makes certain that providers have equal treatment within medical systems, because of course, we are seeking to combat fierce attrition rates within the treatment sector, and we want to make sure to prop them up appropriately. And we're relying very heavily on our representatives from the treatment community on the task force to guide us through that process with expertise and care. We're also looking to our jails and prisons and examining ways in which to provide essential treatment options to inmates, such as medication-assisted treatment. Data show that a large majority of individuals in custody suffer from substance use disorder, and without addressing this, we cannot hope to make a proper impact on both recidivism and setting individuals up for success upon release. And of course, we're continuing to look at overdose prevention and ways to reduce the high cost of medication, strategic stockpiles of naloxone, bulk purchasing with other states, and other innovative policy solutions that I'm very excited about. So with that, I want to thank this committee for the continued interest in the work of the task force. I very much hope to come and present to you on our comprehensive 2019 legislative package as we move forward in the coming months, and I'm happy to take any questions.
I think the proper term to describe addiction is a chronic relapsing brain disorder. I mean, the point is this is a brain disorder, and MRI research data now are so clear that this is very specifically addiction has changed the nature of the brain and creates a very specific set of problems.
Chair Greenlick, absolutely. Yeah, we're absolutely looking at that. Thank you.
Are there other comments? Representative Kenny Geyer.
Okay, two quick questions, I promise. What's responsible for the dip in one particular quarter? And also, what's the plan for the 18% that haven't yet registered if it's mandatory? Have we not hit that deadline yet?
So, Representative Kenny Geyer, Chair Greenlick, the DIP represents a migration of the prescription drug monitoring program to a new platform and the removal of unused accounts from the system in October 2017. So that can be explained there. As for getting more individuals into the system, of course, this effort just went underway. I'll stress that July was when this came into effect. So this data come from just a month later, which is highly encouraging, and we're getting continued updates and, of course, trying to march towards almost 100% registration for the program.
Thank you.
Thank you. Thank you very much. Doing good work.
Thank you.
Selena?
Good morning, Chair Greenlick, Vice Chairs Nose and Hayden, and members of the House Healthcare Committee. My name is Andrea Salinas. I'm the state representative for House District 38, which includes Lake Oswego and Southwest Portland. I'm also chairing the Universal to Access Healthcare Work Group. In December of 2017, Chair Greenlick created a work group tasked with identifying barriers to and incremental steps for moving Oregon towards creating a financially sustainable, universal, and affordable healthcare system. This membership includes bipartisan state representatives like Representative Vial, who would be here today if he hadn't had a prior conflict, hospitals, healthcare systems, providers, the Health Policy Board, advocates, among others. We've been meeting monthly since January in Tualatin or Salem, and we will deliver a comprehensive report to the House Healthcare Committee no later than November 2018 to help inform potential policy strategies for legislative consideration in 2019. The group has identified many barriers that include variables like the federal government and our current political climate. And has there been anything done to date that we can anticipate changing under that federal government or changes in the Affordable Care Act or national policy. We've identified the need for certain federal waivers from the federal government that would allow us to set up our own system in the way that Oregon would uniquely want to. We don't expect to get consensus on one comprehensive proposal, but at this point, we do expect to offer some policy proposals from which the legislature can analyze and consider for introduction in 2019. We had a robust discussion in our April meeting to drill down on what questions the work group needed answers to in order to solve some of the issues with creating affordable, quality, universal health care in Oregon. Essentially, what does universal access to health care mean, and specifically to that work group? We wanted to find a policy pathway to universal coverage. We wanted to provide better care for more people with less money. We wanted to address access issues like the rural-urban income disparities discussions. We wanted to address affordability, address unmet healthcare needs, and cost drivers, the administrative burden, system complexity, and financial accountability, realizing that other work groups were addressing prescription drugs and hospital system costs. While there have been many different ideas that have been proposed, some have gained more consideration than others, given the immediate barriers identified. The one proposal that we've spent some time diving into over the last couple of meetings is a Medicaid buy-in proposal. We've looked at what other states have been doing and the criteria they have used for evaluating a Medicaid buy-in. A handful of states, like us, are currently in the process of establishing potential design parameters on a Medicaid buy-in proposal, including Minnesota, Nevada, New Mexico, and Massachusetts. And under a Medicaid buy-in design, and I know that your work group has also looked at this, Representative Nose, there are really 4 potential goals that national policy experts have identified to date. And this doesn't mean that it's an exhaustive list, but the things that we have focused on are access and competition, affordability, market alignment between Medicaid and the marketplace, and then finally, what this looks like in terms of a single-payer glide path. Our group more recently is focused on two models for a Medicaid buy-in. The first is probably best described as the public option, in which a state-sponsored product is offered on the marketplace. The intent here is to increase competition, which is particularly of interest in states that have limited number of plans offered on the exchange, either statewide or in regions or counties in a state in which there might be only a single carrier offering a plan. And Model 2 is a bit different in that individuals eligible for marketplace subsidies can purchase a Medicaid buy-in off the exchange or marketplace. In both scenarios, those who qualify for tax subsidies would be able to compare plans, either in the exchange or off the exchange, depending on the structure, and use those tax credits to purchase a Medicaid buy-in. At this point, the work group has been asked to go through the key design considerations for Medicaid buy-in and offer comments on the off-exchange model. And the different design considerations include the delivery model. Would we use CCOs to deliver this system or an existing provider network? What are the target populations that we're really trying to include here? What is the benefit coverage? Cost sharing, what will that look like? Provider reimbursement rates, as was mentioned earlier in Representative Nose's statement. And will those reimbursement provider rates, we would like for them to be tied to value and not fee for service. We need to get away from this. Scalability and the financial model, and then finally, the biggest and probably hardest part, implementation and feasibility. We will also consider an individual health coverage mandate in our next meeting so that all Oregonians would be forced to purchase some kind of health care coverage. We'll be going through all the proposals and ideas that have been discussed and hopefully come to a prioritization list of policy options that either deserve further consideration or merit recommendation to the legislature. Finally, I have to admit, the work group is incomplete. We have not had the time to thoroughly examine the finance models and mechanisms that could help us address all of these various goals. But many in the work group have expressed willingness to extend the conversation to next summer after the 2019 legislative session has completed its work and look at the next steps on financing. And with that, I am willing to take questions.
Great. Are there any questions?
I thought you hazed me with a prescription drug.
she's doing as good a job as you did, too.
Apparently. She's tackling everything.
I do. Yes.
I'm curious who's staffing this for you. I just want to do a shout out to all of our droppers.
I was just about
I need to do a
who-
huge shout out to
Yeah, well,
Mr.
I mean,
Droppers.
he did the basic health plan, staffed that when
Yes.
he was at OHA, and I don't know if he's
Well,
involved in that.
Dr. Drivers has done several task forces.
Yes, and which is actually very complimentary to this work group and the work of this, but he has been phenomenal. I think all the work group members would agree with that.
Because I think the basic health plan explored some of these, so it was a good
Yes.
foundation for this work.
Yes.
All right. Well, thank you very much.
Thank you.
Looking forward to, you guys done a great job. I'm looking forward to the report and to going forward.
It's a lot.
You know,
It's like everything. Yeah.
let's see. Anybody left?
Yeah, we have Dr. Vern Sabo.
I know. I'm just kidding. Dr. Sabo, will you join us? We've been putting you off for a long time for this discussion. I really want to make sure you have a chance to talk to us.
Do you change the slide or do I?
Want some help with the slide?
Yeah, I just have one other one. Chair Greenlick, members of the committee, for the record, Dr. Vern Sable representing the Oregon Chiropractic Association and the American Chiropractic Association. And I want to speak to Oregon law. The commissioner mentioned federal law. Well, we also have that language in state law as per House Bill 2468 in 2015, ORS 743B.505. And to back up, this has its origins in the Accountable Care Act. We went first, I've been involved with this all along the way. We went to Senator Tom Harkin when the Accountable Care Act was on the Senate side. He's a very strong supporter of chiropractic and, quote, alternative health care providers. Hate that term. When it comes to common conditions that cause back and spinal pain, I say with the standard of care, but that's a different debate. And he agreed there should be non-discrimination in health care so that consumers can see the health care provider of their choice with their evidence-based interventions. Let me get the next slide. So, with the help of Governor Kitzhaber, this language is inserted into the original draft that our work group worked on. Then Insurance Commissioner Laura Kelly chaired that work group. We met for some 9 months and we discussed this issue over and over and over again as per the intent and meaning of these terms. The statute states, an insurer may not discriminate with respect to participation under a health benefit plan or coverage under the plan against any health care provider who is acting within the scope of the provider's license or certification in that state. The legislative intent, which we voiced multiple times, and dating back to the Accountable Care Act and what was known as the Harkin Amendment, was not to discriminate against a provider relative to participation, meant that you cannot say we're not going to contract with any chiropractic physicians or naturopathic physicians or any licensed acupuncturists. You have to contract with some, and it has to be an adequate network. What it's saying is, in the next paragraph, is that this is not an any willing provider statute. The insurers do not have to allow all healthcare providers that want to be on panel, but you have to allow some where available. As for coverage, the intent there was if it's a covered benefit and it's within the scope and licensure of that healthcare provider to provide, you've got to reimburse them for it. The last piece, subsection 3, this subsection does not prevent an insurer from establishing varying reimbursement rates based on quality or performance measures. The intent was insurance payment parity, meaning you simply can't pay a healthcare provider providing the same service, one provider group, differently than another. In other words, for instance, spinal manipulation, manipulative therapy, what the intent was, you can't pay an osteopathic physician a higher dollar amount for the same service as a chiropractic physician performing that same spinal manipulation to 1 to 2 areas, for instance. However, if in fact, based on outcomes, you do a better job, you could in fact gain a bonus, be paid more, so that any difference in payment parity is based on outcome measures, quality and performance measures. That was the intent of that language. So what we're seeing currently is apparently it appears that insurers are disregarding the provider non-discrimination provisions, and there's really no significant enforcement. And so a lot of that, we believe and we know, is due to confusion. And it's also the carriers, what we would say is somewhat clumsy attempts to address the anticipation and the reality of outliers, those who would abuse the system, whether it's a chiropractor treating excessively multiple visits, or a spine surgeon doing 4 or 5 times more spine surgery than his 3-4 partners. And the confusion, we believe, came initially in 2013 from the Centers for Consumer Insurance Information Oversight from the federal government, who came and posted a flawed FAQ. That was sent to all the states. The states duplicated that flawed guidance in 2013. We had 4 days to respond to it. We did that on the federal and state level, and they pulled all the way back and basically came to the determination on the federal level. CIO, Center for Consumer Insurance Information Oversight, said that, well, we're not going to do anything against any insurers or health plans. This day forward, they make a good faith effort to implement these provisions. The DCBS pulled all the way back and really didn't give guidance and just said pretty much the same thing as the feds. So another issue that came up is also during the Essential Health Benefits Work Group, who were back in 2012 in their final report to Governor Kitzhaber. They were to select a benchmark plan. They picked the Pacific Source Small Group Co-Deduct Plan. That plan predated the Accountable Care Act and the non-discrimination provisions, and certainly predated the 2015 non-discrimination provisions we got in Oregon law. That plan states that chiropractic's not covered, optional rider. Naturopath, not covered, optional rider. And acupuncture, not covered, optional rider. Well, those restrictions were in conflict with federal law, but the work group clearly did not know that. It's a small paragraph in, what, a 2,000-page bill? They were clearly unaware of what they discussed was in violation of federal law and now in violation of state law, in our opinion. So what we're hoping for is to get some clarifying language into statute. Senator Mona Anderson is going to create a work group of stakeholders to work through some of this confusion, and get some clarification, and hopefully through a consensus building process, come up with some clarity and some actions and some language that all stakeholders may not be completely happy with, but something we can live with. I'll be getting together with Chair Greenlick's staff and the commissioner to discuss where they need clarification, where they're having trouble understanding the legislative intent of the original language inserted into House Bill 2468. Chair Greenlick, members of the committee, that completes my testimony. I'd be willing to answer any questions.
Thank you. Are there any questions? Thank you very much.
Thank you.
We'll look forward to seeing a bill, I suspect. Are you asking for a committee bill in this case?
Yes, if you're so willing.
I want to remind you all that if you want to request a committee bill and have it pre-session file, you need to get it, however, by, what's the deadline, next Tuesday?
28th.
Right. This Friday.
Friday.
5 p.m.
This coming Friday. Yeah, we've only had, how many? We have about 3.
Correct, Chair.
3 committee. So we're happy to submit, we're happy to ask for an LC.
All my bills are too controversial for you to ask.
Or don't forget your personal bills.
Don't forget what?
Your personal bills.
Well, personal bills.
Same deadline.
You're on your own with, but if you want a committee bill. But I'll never know. If you want a pre-session file, it's not a drop dead time. You can get committee bills after, and we will get committee bills. I want to thank everybody that testified for staying on schedule.
Yeah.
For amazingly, even with a 10-minute break, adjourned on time.
Yes.
Wow.